Where's my notes? Okay. So, welcome to the 8th Annual Perinatal Depression Conference, Advancing the Village, Addressing Disparities and Connecting the Dots in Maternal Mental Health. And that is what we're going to do today. I'm really excited about it. This conference is sponsored by the Philadelphia Department of Public Health Healthy Start Program and Drexel University College of Medicine, Behavioral Health Care, and Drexel Maternal and Child Program. Input for this conference was also provided by the Philadelphia Community Action Network's Integrated Care Work Group. So how y'all feeling this morning? Oh, woo, woo. Me too. True story, I saw the program for this conference, and I had already confirmed to be the MC, and I said, I want to go to this conference. This is dope. So I'm really excited about today. I'm excited to see you all here bright and early on a Friday. So let me tell you who I am. I am Pam Newman, and who am I? What do I do? So I'm an artist, I'm a mama, I'm a community organizer, I'm a mommy, yeah. He said, wait a minute, I want to be on the mic too, mama. And I am a Leeway Foundation grantee, doing art around some of the work that's happening in this realm. Let's see. So I just want to frame the brain a little bit around this. So it says that the Community Action Network's Integrated Care Work Group had a lot to do with what we're experiencing today. Yeah, I know, baby. Here, I'm a sucker. I'm going to pick my kid up. This is James, you guys. Yes. Yeah, he's a great kid. He comes to the CAN meetings, which I think of as a radical power move because mamas should be able to work without worrying about where their kids are. Truthfully, we should have free childcare. We should have paid parental leave. You know, we should be able to, if we need to, bring our child to work with us if there's, you know, a discrepancy, right? And a part of that, like, you know, not being able to find adequate childcare, not being able to spend time with your newborn for an extended period of time without worrying about your job. Those are all issues that we're concerned about here. As well as the big kicker, which is associated with the CAN, which is infant mortality, right? And Philadelphia is terrible. We're not doing great, okay? And we're specifically not doing great with African American, Black people, right? And so I want to go ahead and say that this is a racial issue, right? So let's frame our heads around that. On this stage today, you're going to see women of color, period, okay? Which I'm like, yes, women of color. So infant mortality is tied directly to how some agencies look at the welfare of the city, right? If we can't take care of babies, how well are we taking care of the people who are making babies? The people who are neighbors to the people who are making babies, right? Because those are, like, they're so vulnerable, you know? And if the most vulnerable are not safe, then we need to work some stuff together. And we're having some panelists come up here today to talk about action, to talk about ways that you can take care of self, ways that you can get further engaged in the work, from numbers to ways to think about things differently. It's going to be a dope day, you guys. I'm so excited. So as a activist, a organizer, a mama, I'm... Mommy. Yeah. Mommy. Mommy. Yes, baby. I'm really excited about today. Okay, can I have 3 volunteers, just really quick? Okay, I saw you. Can you slide out? Okay, all right, come on down. So something that I think is extremely important because this issue is a hot topic. However, the way that it is framed in, like regular white male run media is that this is an issue of fault, right? This is an issue of blame, and this is an issue of terrorism, right? Because it is terrorism. This is a war, right, that we're facing. And I want to change that narrative. Do you guys want to change that narrative? Hey, changing the narrative, ow. So throughout the day, I would love if you guys could tweet and put stuff on Facebook and Instagram, whatever floats your boat. So you 3 ladies, can you come up, please? All right, so I don't really need the mic, but okay. So these ladies are holding up our 2 hashtags for the day, advancing the village. Together we can. Advancing the village again in 2 words, so your brain can say, okay, let's do that. So use these hashtags throughout the day to tell the story of what you see, to talk about what you're learning, to share with your colleagues, your family, your friends, because this infant mortality thing it's a big issue. It's a scary issue. But the things that are already being done in Philadelphia and things that are bubbling up are already working to make change. So thank you, ladies. Can you give them a round of applause? Yeah, definitely. You were chilling. It's like, yeah, I'm up here. Okay, so let's see where we're at. Okay, some housekeeping stuff. Bathrooms are out the door, kind of on the other side of where the coffee is. If you see elevators, you went the wrong way. You want to go right, and they're right down there. Oh, okay, didn't know that too. Sister over here said there's a bathroom right there. Lunch is at 12:15. You'll get another announcement. There's a nursing room in room 132, which is right here across from the elevators. So if you need to feed somebody or prepare to feed someone later, we got you. The creative, resourceful, and whole art space is in that collaboratory room. Got some lavender and some art stuff. You can color if you need to de-stress, because some of these topics are a little heavy, right? So if you need a moment, or if you just had enough conference for right now, because we know how to get, feel free to go in that room, chill, take a moment, text some friends, post your pictures up to Instagram, whatever you need to do. And also, Portia Holland is conducting interviews about pregnant women and moms' experiences receiving medical care. She's at the registration desk. You can sign up with her if applause for you guys. And this is something that I like to do in groups where it's predominantly feminine. I want you guys to repeat after me, okay? I am powerful. I am powerful. I am powerful. I am powerful. I can make change. I can make change. Because I am powerful. Because I am powerful. Sure are. Sure are. Okay, so our first speaker is Dr. Irene Headen. And Irene is one of my colleagues working on a pilot called Newborns and Neighbors. You can follow Newborns and Neighbors Art on Instagram. Dr. Irene Headen is an assistant professor of Black Health in the Department of Community Health and Prevention at the Drexel Dornsife School of Public Health. Her research interests investigate the social and structural determinants of racial, ethnic disparities in adverse pregnancy outcomes. In particular, her work focuses on identifying neighborhood and community factors underlying these disparities and understanding how systems thinking can translate these factors into multi-level interventions to improve Black maternal health outcomes. Central to Dr. Headen's work is placing Yeah, I know. You wanted me to look at you, and I looked at you. Central to Dr. Headen's work is placing pregnancy within the context of reproductive life course and developing ways to understand how structural racism operates over the life course to create racial ethnic disparities during this critical window. She uses both epidemiology, y'all, and mixed methods and approaches to conduct her research. Dr. Headen received her doctoral degree in epidemiology from the University of California, Berkeley in 2015 and completed postdoctoral training fellowship through the Maternal and Child Health Bureau's Centers for Excellence in Maternal Health postdoctoral training program. She was also a postdoctoral fellow in the Drexel Urban Health Collaborative before joining the faculty in 2019. All righty, come on up, Dr. Headen.
All right, good morning, everyone. Can everyone hear me? Okay, great, awesome. I'm a little bit of an animated speaker, so if you ever can't hear me, just remind me to talk into the mic. So thank you, Pam, and thank you, James, for that wonderful introduction. And as Pam mentioned, I'm an assistant professor of Black Health here at Drexel. My office is actually right here up on the 4th floor, so beyond the confines, the end of this conference, if you want to drop by and say hello, I would more than welcome it. And as she mentioned, my work focuses on how we understand neighborhood environment as a structural factor contributing to the disparities that we see in maternal health and specifically in maternal morbidity. So I was more than delighted to be asked by Sammy to give this talk on structural racism and perinatal health. And the goal of my talk today is really to set the stage for us as we embark on a day that is jam-packed full of wonderful presentations and panels, all geared toward how we unpack this complex system of inequity to ensure that Black women and babies no longer have to bear the brunt of adverse perinatal health outcomes. I really hope to plant some seeds of thought for you to carry with you as you move throughout the day, to cultivate these seeds over the course of the next few hours as we share and move throughout this space together. And so to start out with, I'm going to start with a story. And this is a story that stuck with me for a long time, and for me represents not only the unacceptable burden of racial disparities in maternal health, but also, I think, highlights the long-reaching impacts of structural racism in this saga. And that's the story of Shalyn Irving. Shalyn was a lieutenant commander in the Commissioned Corps of the United States Public Health Service. And here you can see her in her dress uniform. She had 2 master's degrees and a dual PhD, so as a lifelong nerd, I really resonated with her story. She was doing the critical work of understanding how structural inequality, trauma, and violence make people sick, and in particular, make Black people sick. Yet tragically, this did not save her from passing away 3 weeks after giving birth to her baby daughter due to complications of high blood pressure. While her story is one of the many stories that lie behind the racial disparities in maternal mortality and morbidity, which we know puts Black women at 3 to 4 times the risk of dying due to pregnancy complications, as well as 2 times the risk of experiencing severe maternal morbidity due to pregnancy, her story also highlights the pervasiveness of disparities across other perinatal outcomes as well. In particular, over the course of her pregnancy, Shallon experienced worries about money, worries about support, and had panic attacks about the difficulties of being a single Black mother in the era of Trayvon, Tamir, and Mike Brown. In fact, if we look at the numbers, according to a 2010 Pam survey, Black women experience an 11% higher prevalence of experiencing one or more stressful life events compared to white women. Additionally, for Black women, the nature of these stressors can be fundamentally different. Furthermore, Shallon experienced anxiety long before her pregnancy, as well as during and throughout her pregnancy. And this is one of the ways in which perinatal mood disorders impact women. And additionally, we know that prior anxiety is a risk factor for another perinatal mood disorder, postpartum depression. And in particular, again, if we look at the numbers, while estimates do vary, a few studies have reported that perinatal depressive symptoms can be anywhere from 40 to 50% higher in Black women than in white women. And furthermore, once women go on to be diagnosed with perinatal depression, there are treatment disparities that are incredibly stark. One study reported that Black women were almost 132% less likely to receive treatment for perinatal or postpartum depression compared to white women. The fact that these disparities in perinatal health outcomes exist, as reflected both in the data and with the stories such as Shallon's that we all know and the ones that we carry with us, is completely unacceptable. A robust body of research has identified a wide set of factors, risk factors contributing to these disparities, and this journey has taken us from individual factors such as presence of chronic conditions, personal and familial history of depression or other mental health disorders, and traumatic birth experiences. Furthermore, there are healthcare level factors relating to access to treatment, such as access to care, insurance coverage, and quality of care. And finally, in the current moment, there's a focus on the social determinants of health, including socioeconomic status, stressful life events, lack of social support, and implicit bias within the healthcare setting. They are now commonly accepted as fundamental drivers of disparities. However, racial disparities across a number of these outcomes still persist. And this fact has led researchers such as me to finally catch up with community knowledge and identify racism as the root cause of these disparities. It is racism, not race, that is the social determinant of health. Work based off of this overdue realization has strived to operationalize racism in the many ways in which it manifests. Research based off of this goal measures racism in ways that captures differences in timing. So is racism happening at the point of pregnancy or long before, even extending back into childhood? Frequency, how often are these racialized experiences and racial oppression and discrimination happening? Domains of experience, by which I mean just is racism happening? Are you encountering it in your school environment, your work environment, walking down the street, the ways in which you interact with the world around you? And importantly, racism as a measure of either personal experience, so something visited on you personally, on your identity, or as a group experience, something that you resonate with because the many intersecting identities that you hold experience racialized oppression on a daily basis. And based off of this work to really characterize racism in the many ways in which it manifests, there's actually been a robust body of research that has linked racism to infant outcomes, including preterm birth, low birth weight, very low birth weight, small for gestational age, as well as maternal outcomes, including perinatal depressive symptoms, prenatal care utilization, and psychosocial stress. However, increasingly, this work highlights that racism operates far beyond the interpersonal experiences that come to mind and are often characterized by this body of research. And in fact, it is actually structural racism that defines a more far-reaching way in which racism impacts health. So now I'm going to get a little geek speak on you. The definition of structural racism is the totality of ways in which societies foster racial discrimination through mutually reinforcing and inequitable systems, and the way that these systems in turn reinforce discriminatory beliefs, values, and distributions of resources. To put it another way, structural racism is the way in which racism and discriminatory processes across housing, healthcare, education, employment, law, and the many other domains that define our daily life construct a standard operating procedure that consistently excludes individuals from access to resources and opportunity while consistently allowing access to resources and opportunity for other individuals. And importantly, this system of standard operating procedure, in turn, works to constrain the actions of entire communities, limiting their ability to achieve healthy outcomes. And an important aspect of structural racism, beyond just the definition of structural racism, what it is not only that it refers to contemporary systems, but that it is deeply historical. And this is a figure from a hot-off-the-presses paper from a colleague of mine, Dr. Shanita Seeley-Jefferson at The Ohio State University, who just published a paper on mass incarceration and future preterm birth risk, which, don't worry, we will be talking about that later in the presentation. In this image, she clearly roots structural racism in the fact that for over 200 years, slavery was not only the status quo, but the economic engine of America. Even after slavery ended, state-approved segregation in the form of Jim Crow in the South and other policies across the nation that continue to uphold racial hierarchy that exposed Black Americans to disproportionate disadvantage still persisted. So now in the era after the Civil Rights Movement, when racial segregation is no longer government approved, we still live with the long-ranging implications of policies that were created during these previous 345 years to maintain detrimental racial hierarchies. And put in a way by Kamara Jones, who is a leading epidemiologist and public health scholar. As she said in her TED Talk on allegories of race and racism, which if you have not seen that, I encourage you guys to YouTube it, Google it, and find it. But as she said, contemporary present-day structural factors are perpetuating this initial historical insult. And furthermore, when we think of structural racism with a specific lens of pregnancy and peripartum health, there's a particular history of obstetric violence that's rooted in the origins of modern-day obstetrics and gynecology that further shapes this historicity of structural racism. This ranges from the origins of modern gynecology, which are rooted in the surgical experimentation on enslaved Black bodies, and women because of the nature of slavery, had no way to consent to these procedures. This is an image of James Marion Sims, who has been referred to as, quote unquote, the father of modern obstetrics and gynecologies, and he's a prime example of this. But also I want to take this opportunity to speak the name of one of the women that was at the hand of his unethical procedures, and her name was Anarcha. And this book actually is a collection of poetry that actually speaks to and speaks the names of and to the experiences of the women who were actually on the receiving end of these unethical procedures. Moreover, the history of forced sterilization that rightly fueled mistrust in the medical system among Black women plays into this history. In my home state of North Carolina, this history was particularly devastating, with this practice lasting till 1977. And in this practice, social workers and state welfare boards could make recommendations for a person to be sterilized. Unsurprisingly, if they were deemed to be a burden on the state or state resources. And unsurprisingly, the people who were disproportionately recommended were women of color and Black women in particular. And finally, the ways in which this history of obstetric violence manifests or plays at the root of structural racism for perinatal outcomes is within this narrative constructed around why Black women do or do not breastfeed. There's a thread of this historical trauma of wet nursing practices that persisted during slavery. Because enslaved Black women were forced to feed their owners' infants, there's a complicated and traumatic relationship to breastfeeding their own children that continues today. And while this by no means structures the full narrative of why Black women do or do not breastfeed, of course there's a complex structural history afterwards, and also the ways in which Black communities are reclaiming and remembering our own relationships to breastfeeding. So it makes a much more complex picture, but this does define an underlying current within the way that this narrative is framed. And so the intergenerational trauma of these events is the backdrop to modern day impacts of structural racism. So when we think about the contemporary structures that constrain Black women's perinatal and postpartum health, including racism within healthcare, financial strain from inequitable economic structures, housing instability, and legacies of racial residential segregation and redlining, threading through all of these factors and across generations are these race-based and gender-based historical traumas. And if we specifically think about the lens of perinatal mental health, these psychological burdens that continue forward from the past can amplify already existing stress relating to the childbearing period. So for Black women and women of color experiencing similar forms of structural marginalization, the experience of postpartum depression or perinatal mood disorders may be rooted in the historical oppressions that communities know and feel, but that systems that surround women may not fully and often do not fully take into account. So with that historical lens, I'm going to shift a little bit, but I do want to acknowledge that this weight and this knowledge is heavy. So carry it in the best way that it is for you. If you need to engage in some self-care in the art collaboratory, feel free. But even as this day goes on, we're wrestling with big topics. So self-care is critical and central to engaging in this work. So now to pivot a little bit to the knowledge, because that's what I do. Based on the knowledge and understanding of how structural racism works, increasingly within public health, we're working to generate an evidence base that accounts for and acknowledges both the contemporary and historical impacts of structural racism. And I'm going to take some time to present some highlights from the literature, because structural racism is big, it's a complex literature. But with the caveat that a lot of these studies focused on maternal physical health as well as infant physical health outcomes, which is not outside of the realm of things that we should be concerned about, but much fewer studies have focused on maternal mental health. However, this work is still relevant to perinatal mental health because outcomes such as traumatic birth experiences as well as preterm birth play into increasing the risk of experiencing postpartum depression. So again, it works as a full system, but of course there's always more work to be done. Furthermore, one of the challenges of generating evidence in this area is the fact that structural racism can be measured across many different domains. So what I hope to do is highlight kind of the most used domains, as well as some new and emerging ways that we're thinking about measuring structural racism, with the idea that these seeds will be planted in you all, and you can take that further and say, actually, structural racism, measures of structural racism that capture this aspect, or those don't even capture any of the aspects that I know and carry in my body. Bring that with you and bring that to moving this work forward. So the majority of research on structural racism and perinatal health focuses on measures of racial residential segregation and neighborhood context. And here what I've put up is actually one of the historical redlining maps, which is the foundation of historical segregation, but also plays a role in current day segregation. And racial residential segregation is usually captured as just like the spatial differences in the distribution of Black populations, usually compared to white populations, but there is a lot of literature expanding on how do we incorporate other racial ethnic subgroups within understanding the spatial discrepancies in where people are located. And it's consistently associated with low birth weight, preterm birth, and gestational age for infants. As well as for moms, it's associated with prepregnancy obesity and pregnancy-induced hypertension. Neighborhood context, which is measured in a variety of ways, which I am more than happy to talk about in depth after the talk, but most consistently captures access to resources, so such as food resources, services, and healthcare, as well as physical and social disorder, which is just a fancy way of saying, are there prevalences or indications of vacant buildings, vacant lots, or what's the level of social cohesion in our social capital within a neighborhood, as well as measures of crime and safety. And neighborhood measures based off of the way that we construct neighborhood context has also consistently been associated with a lot of the infant health outcomes that we saw kind of in the racial segregation literature, but also is associated with maternal gestational diabetes, postpartum weight retention, as well as work that's been done by a colleague linking neighborhood context to increased risk of experiencing perinatal depressive symptoms, as well as social support. So just by looking at these two measures of structural racism, we do in fact see that it consistently and independently impacts both maternal and infant perinatal health. However, those two measures are not the only ways in which structural racism manifests. And work using measures of race-based socioeconomic inequality has been able to capture even more nuances of the way in which structural racism operates to capture both race and socioeconomic domains together. And this is really getting at the fact that there is a racialized way in which economic structures impact Black populations that cannot necessarily be captured by just measuring each part separately. In particular, Brittany Chambers et al., which is a colleague of mine, looked at racial and income inequality by taking a county and basically saying, within that county, what are the number of white individuals who earn more than $100,000 compared to the number of Black individuals that earn less than $25,000, with the assumption that within a certain county, if that gap is large, the manifestations of structural racism that may be in turn constraining the ability of Black women to have good perinatal health may be larger. And this work found, in fact, that both this nuanced measure of both race and economic inequality was associated with both preterm birth and infant mortality. Another study in New York took this even further, because we know that socioeconomic status is not just income. It includes multiple domains of both education as well as employment. This study, again, took a similar approach, but instead of looking at differences at the extremes, said across basically education, employment, and incarceration, if we look at the same level of that measure, so if we look at just percent unemployed for a certain county, what is the difference between the number of white women who are unemployed compared to the number of Black women who are unemployed in that particular county? Again, with the idea that the bigger those differences are, the more structural racism manifests within that county. And in fact, these colleagues found that female unemployment inequities were associated with severe maternal morbidity, bringing in an understanding of maternal health within the context of how we understand structural racism as well. And finally, one of the emerging ways in which researchers are capturing structural racism is by explicitly measuring the burdens of mass incarceration, especially for Black communities. And there's two studies that I think are indicative of how this work is starting to emerge and develop. One is that study that I mentioned beforehand with that graphic of the historicity of structural racism. And this study did some work in Detroit to measure multiple dimensions of incarceration, including admissions, releases, paroles, and as well as the financial impact, measuring costs on prison admissions. And the idea is that it's not just the bodies that are being constrained, but it's also the financial burden that it disproportionately puts either on Black communities or disproportionately puts off on other communities. These authors actually found that it was this cost variable, this cost spent on prison admissions that was associated with preterm birth and did not find other associations with other indicators of mass incarceration in this particular study. And some researchers in Louisiana actually took this a little bit further and said, how about we measure the actual impacts of Black incarceration on these maternal health outcomes? Again, they took a parish-level measure of jail incarcerations among Black individuals and found that it was associated with both preterm birth in Black women, but not low birth weight. And furthermore, when they looked at a measure of white incarceration, they did not find similarly statistically significant associations. And so while this represents a quick overview of the emerging ways in which we are measuring structural racism, I hope that it gives you a sense of the concrete ways that we can not only call out structural racism, but develop measures needed to make sure that it is eliminated. And I also hope that it's put seeds in your head about how this does or does not get us closer to measuring the ways in which this manifests, either for you, your communities, or communities that you know and work in. So to round out, of course, there is still more work to be done. Capturing the dynamic and intersectional ways in which structural racism operates across the many domains will take a shared vision for all who are passionate about ending racial disparities in perinatal maternal health. Conferences such as these are critical to moving forward that shared vision. And so in closing, I offer 3 thoughts for things that could be at the center of this vision. These thoughts are not novel, but I think they're important to bring in the room and highlight as we go into this day together. The first one is one that I probably many of us in this room know and are actively working toward implementing, but it's the fact that we need to bridge across silos and sectors in order to create broad-based solutions. Understanding one domain of structural racism is not enough to shift the whole system. And systems thinking, which is a holistic approach that centers the relationship between parts, as well as collective impact approaches, which is the commitment to a group of actors from different sectors toward a common agenda, are both models that we need to shift the traditional focus on staying in our lanes. And one of the images that I like to bring up, and this is from kind of the system science work and systems thinking work that I do within my own research, is this image of the elephant, which I don't know how well people in the back can see it, but I will explain it. And it's basically 5 people around this large elephant that are put in specific positions, and these people have on those big dark sunglasses, like the ones that you have after you come out of the eye doctor after they've dilated your eyes. So they can't really see that much about the scope and the size of the elephant. And if we were to ask each of these 5 individuals, what does an elephant look like? What is an elephant? This person over here near their trunk would say, an elephant is like a snake. The person on the top would say, an elephant is like a brush. The person near the leg would say, an elephant is like a tree trunk. The person near the tail would say, an elephant is like a rope. And that poor soul that is over there in the elephant poo would say, an elephant is soft and mushy. and While all of these descriptions are technically correct based off of the information that all of these individuals have, it does not capture, obviously, the totality of the elephant, nor does it capture that the elephant works as one moving part, not as separate things. And so I think as an analogy to apply to structural racism is particularly pertinent or relevant because a lot of times structural racism is the elephant in the room, as well as it can seem like a huge and overwhelming task to take on when we only see our part of the elephant. But when we know that there are other people who know about different parts of the elephant, who can tell us about the tail, can tell us about the leg, and can tell that poor person to get out of the poo, we can move forward to actually understand the structures to create change. The second thought that I want to leave with you is that we must center Black voices, and particularly Black women in their communities, in order to make meaningful change in dismantling structural racism. To return to the story of Shalyn Irving, she existed within a system of structural racism and knew very, very well the real impacts of these systems of oppressions on her own and her family's health. She knew the anxiety that she felt as being a product of a Black woman navigating multiple interlocking spaces that were not made for her, and the toll that it took on her health. Yet without ways to capture the totality of these burdens of risk that she carried, the system was not able to appropriately quantify the true risk that she was experiencing, and thus was dismissive of her deteriorating health postpartum with the most tragic outcome possible. Her and her village could not save her at that time. But when we, as a village, listen to and honor her story and the stories of so many women experiencing and navigating these systems, we realize, as a recent paper stated, that the solutions for mortality and morbidity in birth actually reside within the resilience of the people facing inequity every day. Hi, new friends. And finally, we must lift up Black practitioners, health workers, birth workers, and I will admit to being somewhat selfish here, scholars. They represent the dual identity of navigating systems across which structural racism operate from both a personal and a professional level. And I've put this image of the Black Mamas Matter Alliance 2018 Black Maternal Health Conference and Training Institute, first of all, because I am terrible at taking pictures, and every single one of the pictures that I took of this event came out blurry. I know Christy's looking at me like, why? But I also want to call out the fact that it was one of the most eye-opening experiences for me of what it looked like to actually put this into practice, to actually create spaces, conferences, and even working environments and organizations that uplift Black practitioners, health workers, birth workers, and scholars. The questions that we asked were fundamentally different. The insights that we had were fundamentally different. The actions that we took and the solutions that we pursued, even beyond the bounds of that conference, were fundamentally shifted because we did that. And so to end, I hope that over the course of this talk, I've highlighted that through shared vision and collaborative action, we can begin to reimagine how to dismantle structural racism. In its place, we can create systems of racial equity that support Black women who thrive during the peripartum period and beyond. There are incredible actions currently going on and being taken in Philadelphia to move this charge forward and to shift the structures of racial inequity. And over the next 6 hours, you'll have a chance to play in this sandbox, to see and engage with the people on the ground doing these actions, and if you are that person on the ground, to engage with like-minded people and people who can help and uplift your actions in order to create this change. And beyond the structured presentations, we're in a room of folk with both the depth of wisdom and the will to change the structures that perpetuate racial disparities in Black maternal health. It is in this way, by our shared action, that we can connect the dots. But what we do with those connections after we leave this space is just as important. So I encourage you to be an active creator within this village. By the end of the day, I hope that you'll have new insights and new inspirations for how you and your community and your new shared partners can shape this vision and leave with a plan and a partner to move this important work forward. So I'll end there and say thank you and open it up to questions. Do we have time for questions, Pam? Okay. And do we have a mic?
Here, you can pass around this mic.
Awesome. Wait, is that a box?
It's a padded box.
Oh!
It can be.
So I think there, yeah. It's like, that looks like one of those Bop It boxes.
Cool. They have this at CHOP.
I have no idea.
It's great. This is my second time using one, so I'm excited. Okay.
Hi.
Hi. My name is Jamila. I'm coming from Children's Hospital of Philadelphia.
Great.
I work in research, and one of my questions was, what are is there any kind of like documentation about Black male influence in this, or like their part? Because I think a lot of the how do I say, barriers oftentimes come from males or people who are male presenting. So I'm curious, like, in terms of the collaboration or involving them to kind of make just being a mother or being a parent just easier in general.
Yeah. So I think historically, like a lot of this work has not included men, but I think increasingly that gap, which again is kind of like research being like, oh right, men are involved and male presenting people are involved in this, right? Is catching up and starting to understand the ways in which structural racism impacts their perinatal health as well, because it's not only women and women presenting folk that experience that, but also, as you stated, men and male presenting folks. So I think there is emerging literature. It's definitely something that needs to be carried forward. And I also think kind of a thread within that is understanding the breadth of presentation with which people who are pregnant can present in, and having a lot more work done on trans men and other gender identifying individuals who may become pregnant, and how those structured identities create maybe a different or a modified experience of structural racism and the impacts on their health. So I think that's a great question. I will say there's ongoing work. In my particular research, I mostly focus on women, but I definitely, for my work, it's like, again, here's my lane, but how do I partner with a collaborator or someone who's doing that work and can give insights to my work in order to bring that into the fold. So thank you for that question.
Yeah, no problem.
Wait, okay. Can I go there, then pink, and then there?
Thank you. Good morning, everyone.
Good morning.
On your presentation, you spoke about incarceration affecting Black mothers differently than white counterparts. I wondered why that was.
Right. So I think there's a lot of reasons. I think part of it is that when we think about the communities that are disproportionately policed and the ways in which that is a form of, so the incarceration, right, like it has to do with the people who were caught, and the people who were caught had to do with the places that are surveilled, right? And so because Black communities are disproportionately surveilled, and there's a history of that and reasons for that, that weight, especially for Black moms, not only in terms of in relationship to their partners, their families, and their community members, but also in relationship to how they see that manifesting for their children, especially if they are having Black men, can become embodied in different ways than necessarily it is for Black women. And so I think that's underlying it. I think the initial parts of this work are just starting to measure this. I think the ability to really delve down, and again, this is where bringing in community voices, bringing in lived experience to be like, well, the way that it manifests for me, why I would think that is, X, Y, Z, is critically needed. So those are my thoughts on that, and I thank you for that question.
Okay, thank you.
I think I had, and then pink after.
Thank you very much, and I have a comment. I wonder if the gap between occupation between white and Black is bigger than we think, because a colleague of mine was doing audits at her hospital in this Mechanicsburg area of the state, and she noticed in the audits that white women were listed as homemakers and women of color were listed as unemployed.
Wow. I think that comment brings up two things that weigh on me, and things are part of the structure, right? Because again, even the difference in that wording, it's part of that history, the way that we view women who are not currently in the labor force, right? Homemaker versus unemployed, and what that means. So I think that is, I thank you for that comment, but I also think about it in terms of the converse of where when we think about occupations on the other end of the socioeconomic status, so if we think about, again, kind of going back to Challen Irving, where she's a PhD, she should have leveraged the economic benefits or of that employment, but the disparities in these birth outcomes for women at that stage can be just as large or even larger than women who are at the lower end of the socioeconomic status. So I think those are both dual ways in which structural racism manifests to, at both ends, constrict the ability of Black women to navigate systems in a way that they can maintain their health. So, okay, 5 minutes here, and then I know that I neglect this side of the room. So if anyone has a question here, please, you can throw that.
Hi. Okay.
Wow.
So you mentioned that conference you attended where it was just so different and really lifted up the Black women's voice. And I was wondering if you could share some examples of what made that conference so unique or the framing that was different.
Well, I think at the root of that conference, it was bring yourself. There was no ways in which people had to code switch. There were no ways in which people had to say, well, I am a doula, so I have this position, and I am an OB-GYN, so I have this position. They worked really hard to structure it in a way that when you walked in that room, you knew that you could bring yourself, and also what you weren't going to do is recreate the power hierarchies that we often navigate within our daily organizations and our daily lives. And so, yeah, well, I would thank them for that, because for me, and that's why I highlighted, because I think I've been in many spaces that have have with the same intention, but that have not done such an amazing job of really actually achieving it. And I think one of the reasons why this conference was successful, because they were unapologetic about we are centering Black women, Black voices, Black birth workers, and history. So I think that was what was different about it. So. Okay, there's no one over there, so I think we'll go here. I don't know how to get the box to you.
Who's got it?
Good morning. I just wanted to say thank you,
Yes,
and thank you for the discussion.
Yeah.
The only question that I wanted to really know is how are we taking this information and teaching our younger children?
Yeah.
Starting there is, I think, is essential. Junior high school,
Yes.
they're having children early. This information is so important.
Yeah.
How do we do that? And how are
Yeah.
you training other people to do the work, I
Yeah.
think, is essential in communities, in particular, like having hubs.
Yeah.
Hubs are all over the place,
Yeah.
and I think it's needed in every police district, school
Yeah.
district, et cetera, et cetera, et cetera. Can you
Yes,
just
I think,
start
well,
that?
well, one of those ideas that you had, like having hubs. How do we have hubs that foster, cultivate, and move forward this knowledge for community members, and how do we, again, restructure power structures so that knowledge production is more happening within those hubs where youth and young people can come to those hubs. As regards to how are we telling young people about this, I think in terms of my role is like being a professor in this space, and also for me kind of always engaging in training spaces for young people is how I engage with it. But I think there's a critical question about how do we fundamentally get this knowledge into educational structures, which intersects with the fact that educational structures are within this domain of structural racism. I think there are a lot of initiatives kind of uprooting our thoughts about what is, fundamental knowledge, what is critical to be known to live within the world, and how do we teach these structural factors, especially, again, going back to junior high. And that's where I often will collaborate with my colleagues in education who more understand what's on the ground ways that we can actually get this. Because again, it's like moving structures in multiple ways. Like this needs to be known, and there needs to be kind of a direct to the community and to the youth communication. But we also need to shift the structure so that we're not on the back end being like, oh, and learn this other thing and learn this other thing that's critical to you knowing how to navigate the world, but then going back into structures where you're learning something completely different, right? And so I think, that's something that I think critically, yeah. Yeah. You're like, yeah. 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 Thank you. I think we may be out of...
Good morning, thank you.
Oh, great. One more question.
I was wondering whether or not structural racism plays out in infant mortality the same way it does in maternal mortality, because socioeconomics is not a determinant in maternal mortality. Because women with high education and high incomes experience maternal mortality
At the same rate.
the same way as women who are not. So does that play out the same way in infant mortality?
Yeah, so I have it highlighted here just because I wanted to focus on maternal health and maternal mood disorders just for the conference. But yeah, it does play out in the same way. And I think some of the women who are the citations of this work, which I want to highlight, a lot of these women are super dope Black women as well in the academy doing awesome research. So it's really an amazing thing. But a lot of them have done work specifically looking at these measures of structural racism and infant mortality. So yes. Yeah.
Thank you.
So I think that's all my time, and James is coming up to kick me off the stage. But thank you all so much for
There's a lot going on behind this podium, y'all. So thank you, Dr. Headen. Let's give it up for Dr. Headen one more time. Smashing power structures. Yes, I'm with it. Okay, so I'm not going to talk a whole lot right now. We will have a 15. Oh, wait. Before we break, I would like for you to look to your left. Well, this is my left. Look to your left and look to your right. Okay, now that you've looked at this person, I would like for you to say hello and give your name to the person next to you. All right. Good job, folks. Now that that's completed, because saying your name takes about 4 seconds. I know y'all are trying to collaborate. I do want you to collaborate, but not right now. So put it on pause. If you can hear me, clap once. If you can hear me, clap twice. Okay, you guys are good at this. Okay, so now that you've met the person next to you, what I would like to request is that you move your stuff to fill in these seats in the center, because we're at capacity, kind of, and people are going to be trickling in as the day gets later. So just to make it easy for new folks to come into the space, can we fill in some of these chairs so that we are making space accessible? If for some reason you need to be on the end, be on the end, but as possible, please fill in the spaces. And once you've completed that process, we'll have a 15-minute break. Alrighty, thanks ladies and gentlemen and humans. Are we all old enough to remember Welcome Back, Kotter? Is it still in reruns? Welcome back. It's 10:18, kind of running on CP time, or Momma time, whichever one you prefer. All right, y'all get settled. I'm trying to find some of the amazing things that you guys have been posting on the interwebs. Let's see. Okay, Mitchie _Cosme_ said, at school today, there was a conference in the building for one of my classes. It was for advancing the village, addressing disparities, and connecting the dots in maternal health. A nice woman was walking around telling everyone to use hashtag advancing the village in order to spread the awareness of this topic outside of the conference. I hope this helps. Me too. Oh, okay, shout out Rhonda, okay. Let's see. Blossoming Belly's Birth says, grateful to be able to attend this conference today. Hashtag maternal health. Hashtag Black Lives Matter. Hashtag reproductive justice. Another fist for that one. Hashtag reproductive health. Hashtag advancing the village. And how about one more? What else we got? Oh, yeah. Let's see. Thrive Birth Support said, looking forward to this event today and learning about such an important topic. And lots of hashtags. I ain't going to read them all. But together we can. Okay. So, again, please use the hashtags advancing the village and together we can. And just one quick word, and then I'm gonna move on. The CAN, which you're seeing the information boards over there. The CAN is a collaborative of many organizations in Philadelphia that care about issues regarding fetal mortality. So we're all working to change those outcomes. So okay. And I came to the CAN through a community group, which I think I saw a flyer at the library or something, or maybe Corinne shared it with me, my nurse family partnership nurse, a real one. Shout out to NFP. Y'all be doing some real stuff. Hello. Okay, public health. But the community group has been a part of my life for about a year or more, and James has been on that journey the whole way. And the glue that holds that community group together is this woman that I'm about to introduce, so hang on. I'm sorry? Oh, wait. Where am I at? Mommy. My paperwork. I know, baby. Oh, yeah. Psych. I'm on that mommy stuff. I don't have a staple in my paper. I left my actual paper at home, y'all. It's Mercury retrograde. I'm doing my best, okay? But anyway, I'll repeat that again later. So I'd like to bring up Simone Sneed, who will introduce our next two presenters. Thank you.
I was about to say good afternoon, but it's still morning time. Good morning, everyone. How are you doing today? So I have to let you know that I'm really excited to introduce our two panelists today that will go over everything policy related from local, state, and national policy in terms of maternal mortality. I would say that I'm honored to introduce them right now. So we actually have Representative Morgan Cephas with us today. And the lovely Latasha D. Mays. So I'll get into their bios right now. So Morgan Cephas, State Representative of the 192nd District, was first elected to serve in the Pennsylvania House of Representatives in November 2016. A native of West Philadelphia and a product of the public school system, Representative Cephas has worked tirelessly in the public sector to build up her community block by block. At an early age, Cephas realized that successful communities should be safe, offer job security, and have quality education and multi-generational recreational activities for residents. In the General Assembly, Cephas's priorities include increasing career opportunities for youth through education, expanding business, creating jobs, providing resources to seniors, expanding access to health care, and ensuring women and girls are a priority. So that's us. She serves on several committees and caucuses, including the Pennsylvania Legislative Black Caucus, where she is the chairwoman of the Subcommittee on Women and Girls of Color, the Women's Health Caucus, where she serves as the vice chairman, and the Philadelphia delegation. Representative Cephas is also on the Philadelphia Mayor's Commission for Women and an active member of Links Incorporated and Delta Sigma Theta Sorority Incorporated. She is a fierce advocate for women and girls, and most recently has championed the issue of maternal mortality, strategizing and supporting state and local efforts and funding to improve maternal health outcomes. Other issues include dignity for incarcerated women and eliminating the school-to-prison pipeline. Cephas has also successfully secured over $4.2 million for the 192nd District for projects at local schools, parks, businesses, and more. So I'd like to introduce Representative Morgan Cephas.
So I know the Delta Sigma Theta thing killed you, but it's all right. So I first and foremost want to thank you for the Advancing Village Conference to invite me out to have this conversation. As she mentioned, I am from West Philadelphia. Hey. Thank you. But I do want to caution you, it's not the cool and hip part of West Philly, so it's not like, it's not the Drexel, not the UPenn. We have a lot more parking, a lot more trees and grass, but it's also a community that has a significant level of disparities. I am in a community that does not readily have access to healthcare options. We just recently got back a supermarket, but it's in the northern part of my district, so I have roughly at the bottom part of my district a significant food desert. My district borders Montgomery County, and one thing you realize daily is that just across the street there is a 20-year life difference. Mothers are living past their pregnancies and past postpartum. So it's just a staunch difference, and you recognize the challenges that so many neighborhoods across Philadelphia have, so many challenges that families have across Philadelphia. My district is essentially a microcosm of what's happening in Philadelphia and across the country. On the northern end of my district, I have roughly, I have homes going up on the market for $500,000 and up. But on the lower end of my district, I have a 44% poverty rate. Every 28 days, someone is getting shot. I have low literacy rates. You name it, I have it on the southern part of my district. And, I always like to open up these conversations that way because it reinforces a reality of, again, what working families, mothers, parents are going through on a day-to-day basis. So I also like to start this conversation off with about 2 years ago, I had an opportunity as the chair of the Women and Girls of Color Subcommittee to host a roundtable conversation with our Senator Bob Casey. And at that time, it was focused on the agenda for African American women and girls. So we had an opportunity to have roughly around a 2-hour discussion. And a part of the group, we had women from across various sectors, from healthcare, from entrepreneurialism, from recreation, from arts and culture. You name it, we had it at that table. And one of the young ladies during the discussion brought up the issue of maternal mortality. She asked the question, what is the Commonwealth of Pennsylvania doing about this issue? Now, our senator, being a Caucasian male where he's from, he had a bit of a blank stare, but it wasn't okay for myself to have a blank stare. As a young African-American woman around the age of, not going to tell you my age, but we're going to leave that part out. But at the age of where I'm starting to think about a family. And as a result of that question, like any elected official, I took a deeper dive. At that time, I did not see the Serena Williams expose. I hadn't read any of the Times Magazine's article. So needless to say, I was a little bit behind on the conversation. And after having the opportunity to expose myself and my staff to that discussion, I was terrified to even think about starting a family. And fast forwarding to 2019, I actually had a young woman from my district at Lincoln Hall Hospital die during her pregnancy. And she was 34 years old. So as much as we're having this conversation, it's always important to tell the stories behind the data points. So I always like to, lift up LaShawna Gilmore's story because, again, she was at 34 years old. She passed away during her pregnancy, and she leaves behind a young daughter and a young son. And she was from, again, West Philadelphia. And when you raise this conversation, the immediate discussion goes to, well, what is it that she did that led to her death? Was she in a community that had a lot of crime? Was she stressed? Did she have employment? Was she healthy? Did she go to her appointments? And oftentimes in rooms with doctors, and I had a meeting with our 5 now, birthing hospitals, and I had to raise the question or remind them of, well, what's the story with Serena Williams, with her maternal morbidity? I mean, she can afford the best health care with all of us combined. And, she still had those challenges, still had her doctors not listen to her about her own body and about what she was going through. And luckily enough, she had the ability to advocate for herself. But when I think of my own self, advocating for yourself in the midst of doctors who that's their field is a bit intimidating. So I always want to make sure I lift up that story. So, we've made significant strides. After that conversation, I teamed up. I know Jovita Hill is here from the Philadelphia Women's Commission. I have an opportunity to sit on that commission, and at the same time, I feel like it's luck, it's God that the same conversations were happening simultaneously, but she held the commission held a town hall, and it was standing room only. Standing room only of advocates, of midwives, of doulas, of healthcare physicians, really talking through what's happening here in Philadelphia. And as a result of that conversation, I realized that our rates across Pennsylvania as well as Philadelphia are increasing. So my question is, how do we have the University of Penn? How do we have Drexel? How do we have Jefferson? How do we have some of the best researching institutions in the country, and we are still having this issue? So being as though that I am not an expert, and I will be the first politician to say, put yourself in a room with smarter people. As a result of those conversations, I've just been on a listening tour, excuse me, about what we should be doing at the state level. So some of the things that we've considered, one is expanding Medicaid to cover women up to a year during the postpartum period. Thank you. And that is a bit of a battle. Believe it or not, you have to sit across bureaucrats in DHS and in the health department literally tell me that, well, women, if they get kicked off of their health care as a result of, the 60 days ending, they can just go into the exchange. And, I'm like telling them, I don't even know how to operate the exchange. And I can't, and had to really stress that, well, how is a mother, being forced to navigate the healthcare system? Oh, yes, she just had a child. Oh, yes, she has to get ready to go back to work. Oh, yes, she actually has to live life. And you want her to navigate this system when we have the capability of expanding, care. So that's one of the pieces. The second piece would be to expand Medicaid to cover doulas. Thank you. As I know you are the experts, and you can tell me better than I could tell you that doulas have proven, based on research, that they and their assistance to the mother during the maternal period are saving lives. And that is something as the Commonwealth, as a Commonwealth, that we should make sure that we should be investing in. The third piece is to ensure that maternal morbidity is a reportable event. Right now, as a Commonwealth, we are not collecting data around the issue of morbidity, and we know, well, not Philadelphia. Philadelphia is actually leading. Where's Asta? I know she's in here. We are leading in so many different things, but it is a statistic that is not being collected across the Commonwealth of Pennsylvania. Last but not least, which I feel like is one of the more stronger pieces, and actually is one of the pieces that we're getting the most traction out of, is to require medical professionals to take implicit bias and cultural competency training. It is one of the bills that is most supported, but it is also a conversation that we have to realize is how do we actualize that? What does that look like? And I think one of the great things with being in the city of Philadelphia and how we uniquely are able, we have a lot more flexibility around our healthcare system. And I really believe that we can use the city of Philadelphia as a beta test for that piece of legislation. The great thing is that you have to approach when we have a Republican-controlled majority, they don't take too kindly to conversations around implicit bias because I don't believe they think it exists. But one of the great things with being a legislator is that you have to realize that you have to have a multi-layered strategy. So not only do you have the opportunity to introduce bills, but again, once we take back the House, we'll be able to, get them all through. So make sure we get out there in 2020. Not to make this a political conversation, because I know we are a 501c3 in here. But the second piece is how do we use this opportunity and this point in time to shift policy? One of the things that the departments that oversee this issue are talking about is ensuring that the next iteration of MCO contracts, we have embedded things that will help expand access to doula care, tying resources to outcomes. So those are some of the policy things that are being considered to, again, do that shift. The third piece, which I feel like is ultimate, critical, and extremely important, is funding and access to resources. One of the things I have an opportunity to do is sit on the Appropriations Committee. And as a direct result, my colleague and I, who is a Republican, Ryan McKenzie, and I do have to give him credit, young guy, he introduced and was able to usher past the legislation to create the Maternal Review Committee for the Commonwealth of Pennsylvania. So Republicans do get it right sometimes. But we're working together to ensure that we have a line item in the state budget that not only supports the review committees, but goes to grassroots organizations that are scaling up best practices and that are actually reaching our mothers. So that is the one piece that we are focusing on currently. But, you know, I want to thank you for having me and thank you for having this conversation because, again, I am not an elected that knows all things. And I feel like as we continue to have this conversation, we're going to continue to come up with different ideas, different legislative priorities, policies that we need to introduce both on the state and the local level. So I am always here, always open to have conversations. I feel like I'm on my third or fourth policy hearing about this discussion. We do have a conversation coming up during Philly Tech Week. One of the things I'm an advocate about is ensuring that technology and maternal health are intersecting and how can, again, we have the ability to scale up best practices. We have an opportunity, the founder of the Mommy app, has everybody heard of the Mommy? I don't think you could be in this room without hearing about the Mommy app, right? Okay. So the Mommy app is a phone application that was developed over in California. And what it does, it connects mothers. It's almost like a telemedicine app where they connect the mothers to their birthing hospitals so they can continue to do their vital checkups. And if there's something that they see that's a little off, they have a direct connection to their health physician. Now, the founder of that app was invested in by both Serena Williams and Mark Cuban. So we actually had the founder coming out during Maternal Tech Week, during Philly Tech Week, to again uplift that conversation to reinforce how technology and maternal health can intersect to essentially save lives. So we are at a time and we are in a space of extreme innovation, and I think we have to ensure that we continue to uplift this discussion and make sure we keep the pedal on the metal because, again, when I lose a mother in 2019, just last year, in 2020, literally 2020, we are still losing lives. Again, it reinforces that we are far from done from our efforts and we still have a long way to go. So I want to, again, thank you for having me and thank you for giving me the time. And keep up all of the work that you're doing. Make sure you elevate your voice and make sure you have the conversation with electeds and policymakers. So, again, we can make those shifts based on those that are on the ground doing the work. So thank you again.
Like I said, I'm so excited to have you both here today. I think that we are doing amazing work collectively as a community on the local level, the state level, and the national level. So we're going to get into the national level right now. I do have one question that I kind of want both of you to marinate on as we're going through our next panelists, and then we have lots of questions. One question, what can we do as a community to really just improve these drastic rates of maternal mortality, whether that be on the local level? So it's great that we're having these conversations, but can we do something? Can we have boots on the ground? What can we do to make this problem disappear? So if you two can marinate on that, and then I will, it's marinating, it's a lot of marinating. And then I will introduce Ms. Latasha Mays. 1 second. Sorry about that. I was like, I know I've learned a lot, but I want to make sure that I get her bio right.
I was like, that's a short bio.
No. I would not do that to you. So, Ms. Latasha D. Mays is a nationally recognized leader in the field of reproductive justice, human rights, and leadership development for Black women and girls. Ms. Mays is the founder, president, and CEO of New Voices for Reproductive Justice, a multi-state organization in Pennsylvania and Ohio. Yes, and this organization is dedicated to the health and well-being of Black women, femmes, and girls headquartered in Pittsburgh with offices in Cleveland and Philadelphia. Ms. Mays is a graduate of the University of Pittsburgh with a Bachelor of Science in Business Administration, and she earned a Master of Science in Public Policy and Management at the Heinz School of Carnegie Mellon University. Ms. Mays recently served on the Board of Directors on the Groundswell Fund, the largest funder of reproductive justice and women of color. She was appointed to the second term on the Pennsylvania Governor's Advisory Commission on African American Affairs. Ms. Mays is past National Board Chair of Sister Song Women of Color Reproductive Justice Collective. And this is the largest human rights advocacy group for Indigenous women and women of color based in Atlanta. Ms. Mays is also a member of Delta Sigma Theta Sorority Incorporated. Please welcome Ms. Latasha Mays. One moment, please.
Good morning, y'all. I was like, I don't know if I'm gonna make it to this conference this morning. It's been a rough week, but you know what? As soon as I walked in, you gave me life, and Black women give me life every day. And so every day, my commitment is to work for the health and well-being of Black women, femmes, and girls. Let me tell you, I'm so happy to be here because I just moved back to Philly, y'all. So y'all ready to make some trouble? It feels good to be back. I've been in Pittsburgh for the last 20 years. You heard, boo, boo came from over there. See, you know, they're probably talking about sports. They're probably talking about the Steelers and the Eagles type stuff. But I'm gonna let it go. But I did grow up in West Philadelphia. I mean, when Morgan said it, y'all was like, yeah. I grew up in West Philadelphia. Thank you. And so, you know, I left this community not feeling like it was a place for me to continue my life and career. So I said, I'm going to Pittsburgh to go to study, and I didn't think I would be there as long as I was, but I wound up staying there for 20 years. So I always say I grew up in West Philly, I grew up in Philadelphia, but Pittsburgh is where I became a grown-up. And what the things I learned there, I hope to bring to this city, this state, and to this nation through a powerful and transformative movement for reproductive justice. How many of you have heard of New Voices for Reproductive Justice? All right, thank you. We thank you for your support. We just celebrated 15 years of organizing Black women, femmes, and girls, women of color, and LGBTQ plus folks in Pennsylvania and Ohio. And that is no small thing when we're talking about resource organizations that engage in advocacy and organizing and policy. And so we are building the movement for reproductive justice, and it just brings me so much joy to be able to do this work in Philadelphia. So our social impact commitment is that Black women, femmes, and girls get to live a long, healthy, and joyful life, and that's what we're fighting for every day. So let me get back on track, because you know they ain't part of the script. So reproductive justice, how many of you are familiar with the movement, the term, the framework? So we're going to just do a quick crash course in reproductive justice. Reproductive justice is the movement of my life. I always say that that movement, it changed my life and it saved my life, and is the movement that it came from me. We were looking for spaces like this, and this is what makes me so honored and humbled to be here, is that this is what we always wanted to see in the movement that we created. So this is a video. I don't think it'll work, but I want you to go to In Our Own Voice, which is the National Black Women's Reproductive Justice Agenda. If you go to the Twitter accounts Black RJ, Black Women's RJ, there's a video that is a 2-minute video on reproductive justice. And so if you're not familiar with it, please take a moment on your way back to where you're going today to check it out. But the reproductive justice movement was created by 12 black women in 1994. So if anybody tells you differently, then they selling you a dream. It was the genius of black women that created the reproductive justice movement. And if anyone ever asks you, what does reproductive justice mean simply? It is the equation of reproductive rights plus social justice gives us reproductive justice. It is taking the social, economic, and political conditions that we live in. It's the interlocking systems of oppression that we fight against. It's intersecting with what we have known as reproductive rights. So New Voices for Reproductive Justice, we are standing in that legacy of those black women who created reproductive justice in 1994. So our definition is this, that reproductive justice is the human right of us all, and we're going to do call and response. It's the human right of us all to control our bodies, say our bodies, our sexuality, our gender, our work, our reproduction, and the ability to form our families. So this is how we do this work. This is different than what we have seen and how people talk about reproduction and reproductive freedom, but it's important that for black women and black communities that we talk about justice. So there are key elements in the reproductive justice movement that include intersectionality. So if you thought intersectionality was just a hashtag, once again, it comes out of the genius of black women and women of color. Self-help, how we can develop our own solutions, that we have the solutions for ourselves to create the things we want to see in our own personal lives and the work that we do in the nation and communities where we live. This movement centers our lived experience. What we know is that, and if you don't know, we say that your experience makes you the expert. Your experience, you are the expert of your experience. So you don't let no doctor tell you that you don't feel what you're feeling, you know? Or you don't let people in your life tell you that what you feel is not valid. So that is you being the expert of your own experience. The reproductive justice movement is today and forever will be led by black women, femmes, girls, women and femmes of color and indigenous folks. We created this. It is ours. We created the movement, the framework, and the practice. It is intergenerational. And let me tell you, that's sometimes a challenge in New Voices. The youngest person at one time was 17. The oldest person was 69. This is a lot going on with that. But we make it work because we need the knowledge of our elders and we need the vision of our young people. And so that is what's driving our reproductive justice movement. It is based in race, gender, and economic justice. If you're not talking about any of these things and talking about reproductive health and rights, you're not talking about reproductive justice. And that our work is about movement building because this work is long term. I hope that in my lifetime we wouldn't need this movement, but I don't suspect that that will be the case. So what's the vehicle that's going to carry us to our vision for black liberation and reproductive justice? I did a little extra thing on the PowerPoint here. See? put a little stank on it. I was like, that worked well, okay. So, as any movement or framework, it evolves. And so this is what it was when the Black women came together in 1994. And we kind of call it Reproductive Justice 101. And it's not to denigrate it, it's just to say it's where we started. But we can change. We can bring more people into a movement. We can talk about more issues than we have before. And we can change our strategies as we need to. We can't be a stagnant movement. We have to be able to shift and regenerate and become the movement that is appropriate for today. And so the foundation is that all women people have the human right to decide three things: if and when they will have children, if and will they won't have children, and how they raise and parent their children, but free from individual, community, and state-sanctioned violence. And so what we're talking about today is the ways in which institutional and state violence can control our bodies, and that's what reproductive justice fights against at the most fundamental level. So I'm going to shift here a little bit because I want to get into the policy. Now, I had like a whole policy book to go through, but I just think it's important to give you an overview. Sammy's going to share some documents that you can reference as we begin to look at policy. Policy is very dry and boring, so I'm trying to make it as juicy as I can for y'all today. But it's policy that shapes these conversations. It shapes the outcomes that we're trying to change. So in talking about policy, it's important for you to understand the work of New Voices. I have the distinct honor of being one of the founders, along with my three co-founders. I always name them: Becca Zayla Mguni, Maria Dautruche, and Lois Tony McClendon. We are the ones who created New Voices for Reproductive Justice. We are clear about our mission, that it is for Black women, femmes, and girls. We do welcome allies, but you got to be down. If you're not down, it's not for you. And we're unapologetically Black, unapologetically feminist about the work that we do. Our mission is to build a social change movement dedicated to the health and well-being of Black women, femmes, and girls. And as you heard, we do operate across Pennsylvania and Ohio. So we are holding it down in the Rust Belt. And our mission, our commitment, and our vision for the next 15 years is to expand to 15 new cities. So we rocking and rolling in New Voices. The 4 ways that we do our work include leadership, community organizing, policy advocacy, and culture. And so while I can get into all of that, I'll focus on policy. New Voices advocates for policy change at the local, state, and federal level. The majority of our work, and we have the great honor to work with Rep. Cephas as well at the state level on all manner of policy. And then let me tell you too that Black women in state legislatures are the most visionary, progressive, and committed to reproductive justice than anyone else. And so it's our joy to work with them. So New Voices has 3 priority issues: Black maternal health, abortion access, gender-based mass incarceration. We work on a variety of issues, but we're realizing that at this point, this is where we can make the greatest impact. This is where we have the greatest capacity to make a difference, and this is where we have the greatest resources to make change. We also focus on environmental justice, healthcare access, and LGBTQ rights. We consider all these things to be reproductive justice. It's about intersecting all of these ideas. So there are a lot of policies moving right now at the congressional level. I would say that in the time that I've been doing this work, this is the most legislative action in Congress on maternal mortality to address the shameful and unconscionable disparity of healthcare outcomes for Black mother and pregnant folks. So one of the things that I was inspired by was the creation of the Congressional Black Maternal Health Caucus that was launched last year by Congress members Alma Alma Adams from North Carolina and Lauren Underwood from Chicago. So they launched this on April 9th, 2019, and their goal is to raise awareness within Congress to establish Black maternal health as a national priority, explore evidence and culturally relevant policies, and to explore and implement best practices, which I thought was really visionary because there's a variety of caucuses. But for us to have a Black maternal health caucus in Congress is significant, and it's part of the culture change that's needed. If we know the statistics about the federal maternal death rate, 18 in 100,000 live births, the Black U.S. maternal death rate is 40 in 100,000 live births. We know that urgent action is required to address Black maternal mortality. And we know that that happens at the federal level, but this work also happens in the states. So the Black women in the Ohio House of Representatives, they also created the Ohio Black Maternal Caucus in April 2019 as well. And so right now there are 12 bills in Congress. This is the 116th Congress. There are 12 bills in the House of Representatives, and 7 of them have companion bills in the Senate. So I think that's an indication of a very strong appetite to move as much as we can while we have the majority in the House. The Senate will be more challenging, but to have 7 of the 12 bills have a companion Senate bill is important, and you should know that it's you you are the ones who are creating this change and driving the urgency around policy advocacy at the congressional level. So here's the first set of bills. I'm not going to read them to you, but they all have mom in them in some kind of way. They figured what you do, you try to make your bill sound like you give it an acronym to represent what it's for. So it's the Moms Act, the Mommies Act, the Mamas Act, the Mom Act. Any way you can say mom is in there. And so these are the first few. I highlighted the congressional, see, I forgot I did that again. I'm going to talk about the Moms Act. I'm not talking about that. So apparently I just put it on all of them. The Mamas Act, I will be talking about the Mamas Act. All right, y'all, I'm sorry. Okay, I was just trying to get to this page. I'm also going to talk about the Healthy Maternity and Obstetric Medicine Act. So you can see the variety of bills that have been introduced. So when you get the documents that follow up, take notes. It's not difficult to find this. You just go on the Congressional Bill Tracker. So if you want to take note of any of these that sound interesting to you, they cover a variety of topics that I'm about to discuss with you next. So out of these bills, the policy trends echo what Rep. Cephas just discussed, is that 60 days is not enough for somebody who just brought a human being into the world to recover during postpartum. So many of these bills include an extension of Medicaid coverage to 1 year. There is a lot of research and data on the power of doula care and the effectiveness of doula care, and trying to figure out the best ways to either fund it, to expand it, or to make it part of care. Perinatal quality collaboratives are all up and through these bills as well. Implicit bias training. But what I want to say about that is, can we train racial bias out of healthcare providers? None of the bills talk about racism. They largely talk about discrimination. So if we can't confront what we're actually fighting against, how do we expect to solve the problem or to solve the issue? Rural communities is a trend within these bills, and extending networks so they could have greater access, and maternity health models. So you all know the best models, the best ways to serve mothers and parents. And so now in these bills, there's funding for it. There's opportunity to research what are the best practices. And also, I saw pregnancy medical home models and lots of demonstration projects. So these bills would include all of those things, but I just wanted to pull out some of the trends. Very quickly, I want to talk about the Helping Medicaid Offer Maternity Services Act. So this act, I'm going to give you the bill number, but again, you'll have this document after the conference. It's in the House of Representatives, HR 4996, sponsored by Rep. Robin Kelly, a bad sister from Chicago. 24 co-sponsors, 16 Democrats, 8 Republicans. The purpose, again, is to extend postpartum to 1 year and to look into, to conduct research around coverage of doula care for maternal health. I'm mentioning this one because it actually has come out of committee. So this is and so if you know anything about policy, and I hear Rep. Cephas amening me over here, if it goes to committee is where bills go to die. So if it makes it out of committee, we're looking good. So it came out of committee back in November. And so now the report, which will discuss what the bill is for, the scope of the bill, and the case for recommended approval from the committee, it will be scheduled for a vote on the House floor. So this is an opportunity to take action at the federal level for the Moms Act, HR 4996. The next bill, which you might have heard of more so than the other bills, again, Rep. Kelly, Senator Dick Durbin, both of Illinois, the Mamas Act, HR 1897, and Senate Bill 916. So this is a bill that has a Senate companion bill with it. The bills literally look the same. One is for the House and one is for the Senate. The purpose of this bill, and this bill actually has 105 co-sponsors in the House, and it has 16 co-sponsors in the Senate. So again, there seems to be momentum and an appetite to move policy right now in Congress. So there's implicit bias and health equity training for clinicians, also extends Medicaid coverage for postpartum to 1 year, as well as funding for perinatal quality collaboratives. It actually recommends an increase in funding. So both of these have been referred to committee, but the funding request is $150 million over the next year. That is a huge investment from the Congress into these core issues. Just the other day, Senator Durbin called for the immediate passage of the Mamas Act. This was March 3rd, so literally on Tuesday, the other day, he said that this is one of the most pressing health concerns in our nation. So we're likely to see this bill move throughout the spring. So if there's an opportunity to act, this would be another bill to pay attention to. And lastly, this bill is special to me because I love me some Bonnie Watson Coleman, representative from New Jersey, our neighbor, just across the bridge, as well as Sherrod Brown, who is the Senator Sherrod Brown, who represents Ohio. They have introduced the Healthy Maternity and Obstetric Medicine Act, HR 2778, Senate Bill 1481. Rep. Bonnie Watson Coleman's bill has 87 co-sponsors, and Senate Sherrod Brown's companion bill has 24 co-sponsors. So the purpose of this bill is around creating a special pregnancy enrollment period for insurance and group plans. So now we're not just talking about Medicaid, which I think is important to uplift this bill, because we know that Black maternal mortality is independent of income and education. So we can't just talk about Medicaid. So health insurance plans, sometimes you can only enroll during certain times. The Affordable Care Act changed that so that you would have the main period, but if other life events happen, you can still enroll. So now we're saying to add, I said we, like I'm in Congress. I did run for office, but I did say we. That's a whole nother conversation. But now you can have this special enrollment period for pregnancy where you wouldn't have to wait till the next open enrollment if you have an employer's insurance. And so that's huge. to allow people, pregnant people, to be able to enroll at the time of pregnancy, not just during a very finite period of time. And the other piece, once again, the commonality in all these bills is around postpartum coverage for up to 1 year. Both of these bills have been referred to committee. No funds were requested in this bill or the first bill I mentioned, but it's being reviewed, and the bill extends this bill. It's about the private insurance piece that I was beginning to be worried about. We know Medicaid is so important, but we also have to look at folks who are not covered. Their health insurance doesn't come through Medicaid. So that is just I hope, a very short but effective review of all the different bills, and I can talk about them a little more in detail. Again, I'm going to share another document. Sam is going to share another document with you after this is over. I don't want to take no more stuff from up here. The last thing I just want to mention is that February 25th, New Voices and Reproductive Health and Rights colleagues, we hosted a reproductive justice policy briefing with City Council, led by Helen Gim and your 3 new City Council members, who really want to focus on what policies we can create at the city level. And so I just wanted to share with you briefly, and this is included in the documents that will come to you, our recommended changes, the changes that New Voices recommended. We proposed that City Council members, staffers, and employees receive Reproductive Justice 101 training on a semi-annual basis. And we would love to see that happen this year. Like, what can we actually introduce that we can change? Another huge recommendation for us is the focus on eradicating Black maternal health in the city of Philadelphia through a variety of interventions, including, what's the support for funding invested in community organizations, endorsing National Black Maternal Health Week, which is April 11th through the 17th this year with a City Council resolution. We also talked about the creation of a Reproductive Justice Commission in the City of Philadelphia government. We also discussed the end of shackling of pregnant and incarcerated women and folks. In Riverside, we know it's still happening, and we know that it has to end. And New Voices worked to get that legislation passed at the state level back in 2010, y'all. But we need no shackling at any point of pregnancy, birth, postpartum. And so that's the next step for that type of legislation, is to end shackling in the Riverside Correctional Facility and in the Commonwealth of Pennsylvania and across this nation. That we can do this year. That we can make happen, and it doesn't require a dime. So we want to end shackling right here in our county jail. And then lastly, I want to invite you, not lastly, but almost lastly, the All Above All Bold AF, and that's exactly what it means, bus tour, April 29th. New Voices is anchoring. It will be at Love Park from 11 a.m. to 3 p.m. We want to invite you all to this bus stop. It's a pretty cool bus. It's a 23-city tour across 20 states over the next year. And New Voices is anchoring in Philadelphia, Pittsburgh, and Cleveland. So we hope to see you at our April 29th stop. Again, a recommendation to City Council that we want them to continue their commitment to reproductive justice and reproductive health and abortion access specifically. So something I'm really excited to share, and one of our wonderful partners is in the room. Give it up for Oshun Family Center. Together with In Our Own Voice, National Black Women's Reproductive Justice Agenda, and the incredible Rep. Morgan Cephas, who is here with us today, we are hosting Black Maternal Health Advocacy Day in the state capitol, May 6th, Harrisburg, PA. We're trying to organize 200 Black women, femmes, folks, and our supporters to be there. It's over 200 people in this room, so mission accomplished. But are y'all gonna get on this bus with us on May 6th and go talk to these folks that Morgan is talking about, who don't care about the health of Black women, Black mothers, and mothers in general? So we're trying to organize folks from across the state. And this is, again, it's inspiring because we can create the change that we want to see. Please mark your calendar, May 6th, Harrisburg. You can email me directly, latasha@newvoicespittsburgh.org, LATASHA. If you want to go, if you want to get on the bus, if you want to support people in going by paying for the cost of participation, if you want, your organization wants to endorse this advocacy day, we are working feverishly to get all this information to you next week. May 6th is going down. And with that, thank you so much. I appreciate you and happy to be here.
Oh, sorry, hit your head. Yes. I feel like I've said thank you so many times for both of them joining us today and just giving us lots of information in terms of policy, what that looks like on the local level, the state level, and the national level. I do want to be cognizant of time, so I guess we might have time for one question. Does anybody have any questions?
Can I talk now? Oh, okay. Okay. I know, so cute. Okay, so I have to write my stuff down when I'm excited, so excuse me for not looking at y'all. Thank y'all so much for your presentations today. My name is Zahada. I work over at Access Matters, and I want to first just talk about how we're actually doing that implicit bias training right now. We would love to put our name in the hat to help with whatever you're trying to do to get that for providers to start doing that mandatory training. We're teaching the Department of Health right now, so we want to definitely be a part of that any way possible. But my question, what are we doing to lift up and address the birthing disparities faced by trans and gender-expressive birthing parents? Folks, when we often have, a dearth of information to even really lift up those stories, just want to know what's being done.
So what I was, can you hear me? Okay, what I was surprised by in the federal bills is that they don't say women, they say individuals. And I think that is essential. And it is a departure of how we have looked at maternal health. And I appreciate your question, but that was the most striking thing that I saw. Almost all the bills, from what I can see, all the bills said individuals. And that's an important piece of this conversation that we aren't lifting up in the ways that we should. In New Voices, we always talk about pregnant women and folks to make sure that people feel that we are talking about and fighting for them. LGBTQ plus folks lead New Voices, have been essential in our advancement in New Voices, and have been essential to the policy change and community organizing for this work. But we have to look at even a broader system of healthcare access, especially for trans folks and non-binary folks. And how do we change our institutions, but also how do we change our organizations, in social justice and in maternal health. And I think that we have made some strides, but we haven't made nearly as much as we have needed to. I think there are places in Medicaid that we could also expand coverage for trans folks. And we saw, I think in Ohio, a bill was introduced to prevent trans folks from accessing care through Medicaid. So those are some of the things that I would say that we could do. But the federal bills do not specify gender, even though they're very gendered names on the bills. But the actual bill, it says individuals.
No, yes, we need to clap that up. So on the state level, we unfortunately we're not that progressive. And I don't even want to say that's a progressive idea, because it's not. It's just, individuals living life and us as a government recognizing that identity. So what we've had to do on the state level is actually introduce two separate packages. One where we do identify the gender, and one where we identify the gender as just individual. And we literally had Republicans, because the original bills we had specifically around women that are incarcerated, we tried to put in individual or those that are incarcerated, and we could not get Republican co-sponsors if we didn't change it to women. So we then have had to, again, introduce two package of bills, one where we are more inclusive and one where we are gender specific. So sadly to say, we do not mirror our federal government, but we do recognize that this is an issue that we have to tackle, and we have to be as inclusive as possible. So that is why we just have to do double work as we, go through the legislative process.
Thank you. Okay. And just my last question, just so that we can wrap up. How can we advocate for more policy changes? What's something that we can do if we have boots on the ground?
Well, I already answered my question. May 6th, Black Maternal Health Advocacy Day.
Yes.
Harrisburg. Mm-hmm. We have to, let's fill up the building. I think Rep. Cephas can agree that when Black women especially come to the Capitol, it's always like, what's going on? Is there, is there a hair
they get
show
nervous.
here? What's going on?
A hair show?
Because the paradigm is like about who leads and who can create change and who has power.
Yeah.
And that's where power is. And so when people come there to confront power, it makes a difference in the visibility for the issues that we all care about. So that is the next, very next thing you can do is to come with us to Harrisburg on May 6th and show up and show out. That's the best thing we can do right now. Yeah. That's my answer for my request of you. And I think it's going to make powerful change. It has not been done in this manner before.
For me, it's, again, join us on the 6th, of course, but stay vigilant in the organizations that are moving this body of work. I think to have my soror here in Philadelphia is just going to change the conversation for specifically Philadelphia, but because we are the largest municipality across the Commonwealth, the voices that come out of this city, come out of this municipality, can move the direction of policy. So I am beyond excited to have her now permanently in the city of Philadelphia. Permanently in Philadelphia. And I think it's critical to ensure that this is a conversation on every elected official's mind. To have the question asked, what are you doing about maternal health? It forces each of us to really think through, what are we doing? What policies are we pushing forward? How are we making this a priority this budget season as we're asking each department about their priorities, but the priorities that they have on their minds? But also, how are we moving a legislative agenda that reflects the faces of the city of Philadelphia, the challenges of Philadelphia, and how do we ensure that we're not having the same conversation that we're having today next year? And I think the great thing, not so much for us, but for constituents, is that there's an election every 6 months. And, we want to ensure that we're holding people's feet to the fire, moving the needle on issues that we care about, and making sure we're uplifting organizations that are driving this conversation. So I think that is one of the ways you can stay connected. And when you see things that are happening in other states, you can always ask the question, well, what are we doing as the Commonwealth of Pennsylvania? What are we doing as the city of Philadelphia? And we should be a leader in this conversation. Again, given the access to medicine that we have here in the city of Philadelphia, this should not be an issue that we're trying to tackle. We should be able to have mothers that can live a fruitful life and have access to the resources, access to opportunity, so they can, live a life where their families are protected, they're protected, and it's, far past time for us to not still be having this conversation in 2020.
Absolutely. So again, I want to thank Representative Cephas and Ms. Mays for being here today. We really appreciate you taking the time out of your day to join us and really enlighten us on what's going on in policy. I learned a lot. I'm like, I should be taking notes. But just by a raise of hands, who's going on May 6th? Because I know I am. We really need to make a difference. So if we can gather together and really make this happen, I think it would be wonderful. So I just thank you
so much.
There's a break.
That was awesome. I always can't tell if I can hear myself or not. Okay. Hey, y'all. So I'm not sure if I said it earlier, but if you are seeking CEUs for this event, the program says that there's 4.25. There's actually 4.5. Okay. And I kind of shortchanged Simone, so I'm going to read her bio real quick because I have her bio. So I just want to read it to you real quick, and then we'll break for lunch. Okay. Simone, MPH, CLC, is a public health professional dedicated to decreasing the rates of maternal morbidity and mortality among Black women in the United States. Simone received her MPH from University of Pennsylvania and her Bachelor of Science degree in Public Health from Temple University. What's up, Temple? Simone's research has focused on the role of doulas in childbirth, maternal and infant mortality, and the impact those tragedies have on African American women in the United States. Simone is the Maternal Mortality Review Community Action Team Coordinator with the Philadelphia Department of Public Health. Simone is a certified lactation counselor and birth doula. Some of her greatest accomplishments are supporting families as they experience the beauty of birth. She truly believes that no woman should die while giving life and is making it her mission to decrease the high rates. Yes. Yeah, that's it. That's the last sentence. Okay, so that's Simone. Okay. All right, so we're going to take a 5-minute break. Please be back at 11:15. 30. Oh, yeah, because it's CP time. Connect with some of your neighbors. And I mean, in the grand scheme of things, we are neighbors. We're all in this together. This is not something that we can accomplish with just a few people, as was just shown to us in this previous panel. Not the wires. Okay. Oh, this is exciting. Hang on. Where's my... Girl? Here, why don't you sit down here? Okay. So, who's learned something today? Who's met someone new? Who feels like we have a group here that can make sustainable change? Me too. I really feel like it's super important in any kind of organizing work. Like specifically, we're talking about reproductive health, maternal mental health, right? But I think in any issue, think of one. Black women, trans people, indigenous people are always leading the way, and I think that, we just need to listen sometimes. Listen, take things seriously. But now, I was really eager earlier. I was a little eager. I want to introduce Cynthia Estermera Gauthier. She's going to introduce our panels. Cindy is the Equity Engagement Lead and brings her experience as an educator, humanist, expert facilitator, and equity practitioner to her work with Strategy Arts. She supports Strategy Arts clients to bridge the gap with their communities. Through this work, Cynthia has a superior record of fostering dialogue in marginalized communities while supporting the development of coalitions and collectives that work to solve societal problems nationally and across the greater Philadelphia region. Cynthia specializes in safe space facilitation and creating diverse, inclusive, and equitable initiatives that amplify the voices of marginalized peoples. Cynthia holds a BA from the Pennsylvania State University and an MA from Villanova University, both in English. She's also a PhD candidate in English and Africana Studies at Lehigh University. Cynthia has authored several pieces and has been featured in podcasts and documentaries like UCHRI's Voices of Diversity and Uhuru, Rooting Our Voices. She's been invited to present at several local and national conferences to share tactics and strategies for how nonprofit and government agencies should equitably engage historically underserved communities in their programs and initiatives. I knew that was coming. Cynthia is actively supporting coalitions and collectives like the Community Action Network, aka the CAN, and the Women's Economic Security Initiative, Organized Voices for Action, and a Running Start, Health in Implementing Equitable Community Engagement Practices. Give it up for Cindy.
Hey, James. So James and I have a long-standing relationship because I met him when he was 8 weeks old, at our first community group that we hosted for the CAN, and I've been facilitating meetings with him in this space for over a year now. So give it up for James, my co-facilitator. Thank you, Pam, for that intro. And also, I want to give a shout out to Sammy in the back, Samantha Schuster. Y'all know who she is. She is the CAN coordinator. She works for MCFH, and she's been making the logistics for the CAN community group and the logistics of this amazing conference happen. So when y'all heard Latasha talking about get to Sammy for that paper, that's Sammy. So she's been making these spaces what they are. And I'm humbled to be in this space today, and I'm going to jump in and introduce the amazing panelists that are here, and then we're going to have a conversation. We're going to have a conversation about tools and healing and self-advocacy so that we can begin to combat the silence. So I'm going to jump right in. We have Jaleesa Jones. She is a mother, trained birth doula, certified lactation counselor, and a certified wellness coach who advocates for breastfeeding and equity in areas of health, wealth, and education through her work. She believes that by planting a seed today, you may only water this generation, but you will feed many generations to come. She is also a writer and spoken word artist and likes essential oils. Give it up for Jaleesa. We also have Asta D. Mehta, MD, MPP, and she is the Women's Health Policy Advisor for the Philadelphia Department of Public Health and OBGYN clinical faculty at Pennsylvania Hospital. Dr. Mehta completed her OBGYN residency and public policy women's health advocacy fellowship at Drexel University, right here, College of Medicine. With the support of Drexel University, Dr. Mehta also completed a master's degree in public policy. Her public health work is focused on programmatic implementation to reduce maternal morbidity and mortality and improve women's health in Philadelphia. Dr. Mehta also co-chairs the Philadelphia Maternal Mortality Review Team, leads the Philadelphia Labor and Delivery Leadership Group, and serves as vice president of the Obstetrical Society of Philadelphia and as a member of the ACOG National Patient Safety and Quality Improvement Committee. In addition to her leadership roles on the local level, she also represents PDPH, Penn Medicine, and ACOG at the state level as a member of the Pennsylvania Maternal Mortality Review Committee and the policy chair of the Pennsylvania Quality Care Collaborative. Not to mention, she is working on a podcast with her best friend. It's going to be called Gin Fizz, where they talk about topics bubbling up in OBGYN. Give it up for Dr. Mehta. Next, we have Candace Shillingford. She is a social worker in the city of Philadelphia with a focus on children and families. And throughout her time in college, she has centered her studies and research on trauma-related experiences, attachment theory, adverse childhood experiences, and neurobiology in reference to children and families, as evidenced by effective parent-child interactions, interpersonal skills, and reverse health disparities, by discussing and implementing positive coping strategies to build resiliency. Following her interest in continuing to work with clients and broaden her work to alleviate health disparities in the Black community, Candace is a community birth doula and co-founder and creator of the Black Maternal Health Week. Her vision and passion are to bring forth awareness, education, and resources to the Black community to build resilience to decrease health complications and adversities. She also dances every single morning. Give it up for Candace. And lastly, but not least, we have Marquita Taylor. Marquita Taylor is a mother, artist, writer, birth justice advocate, and traditional student midwife who works collaboratively with mothers, community collaborators, and local birth workers to directly bring awareness to issues centered around parenting, pregnancy, and the years immediately following childbirth. From direct service and public speaking to facilitating events and workshops to managing birth workers and a workers' co-op, Marquis is a visible resource and voice regarding the Black maternal and infant health crisis in Philadelphia. She is also a 2020 second place winner for the Philadelphia Social Innovations Awards and a curriculum developer for the pilot program Newborns and Neighbors out of the Community Action Network. She also used to be a competitive swimmer before Simone. Give it up for Marquis. So I'm also an animated speaker, so if I drift too far from the microphone, let me know. I want to make sure everyone has access to hear what we're saying. And I'll just open it up with the fact that I am not a medical professional. Yes, I am not. But I've been humbled to be a part of the conversations, the layered and dynamic conversations on a regular basis, almost every single day. Like Simone said, I should probably get some office space in the Department of Health. But the conversations are not just happening at the structural level. So we talked a little bit earlier about, structural racism, and we whittled it down to what that policy looks like at the local level and at the federal level. And there are all these big meta pieces happening, but we also have power here, right? And we also have the ability to have conversations that are not happening in those spaces. Like we have some of these conversations in our kitchens and with our friends and family, and we talk about the ways that things are impacting us as individuals or us as patients or even as providers. And so we know the problem well, but we also know the solutions really well. We know the solutions, y'all know the solutions. Can we say we know the solutions? We know the solutions. Right. So I'm going to echo a little bit, and then I'm going to throw a question to the panel that, Rep. Cephas said many times doctors don't listen to patients, and we know that that happens especially with women of color. And it can be an intimidating process to speak up and to advocate for oneself. And like Latasha said, you are the expert of your own experience. So what are some ways that you feel pregnant women and new moms can advocate for themselves when they're with a provider? So how can Momma speak up? I know Marquis and Jaleesa, I see y'all. Go ahead.
It's a layered question. Yes. All right, so one of the things that I tell clients that I work with are just,
Pull it closer.
Hello? Oh, okay. Can everyone hear me?
Yes.
Okay, so one thing that I always tell patients or clients that I work with, and also family and friends, is advocating for yourself starts by knowing what your needs are. So write down your questions and concerns sometimes ahead of time. A lot of times you forget what are important to you or things you want to be addressed, and then life happens. You get to your appointment, and you get in and you get out, and you're like, oh, I forgot to ask about this. Also, taking pictures, so documenting if you can or if it applies. Taking pictures or videos if there's some type of health-related thing that has occurred that you feel you want your physician to address, because lots of us have it where you have a rash or you have something that happens and you get there and it's better. And so words can be discounted often, but a picture or video cannot. Bring a support person, family, friend, partner, worker, case manager, doula, someone who can be that second pair of eyes that can emphasize, like, hey, I'm not being heard, or like, did you understand that? So 2 against 1 sometimes can be more impactful, or they feel like they're being held accountable, because sometimes they'll dismiss a patient that's asking a question because there's no one else who is there to see. And then lastly, making sure that you just ask, like, hey, I don't really understand that. Could you repeat that? Could you say it again? Or what does that mean? What are my options? So not just accepting what you're being told or getting as a treatment plan or a medication, but like, is this necessary and what are my options?
I think I've had the very fortunate experience of, particularly as a doula, starting care with clients pretty early on, like previously, like prior to them finding who their provider is. And so that puts me in a position as a doula where I can do one of the main core tenets of advocacy, and that's educate. I know that there's a lot of doulas who focus very solely on like the one-on-one personal like support, but I think that it really starts at the course of education. You can't advocate for yourself if you don't know what is supposed to be in a birthing situation. What is legitimate? If someone says, hey, you have to get an epidural, is that real? Is that not real? If you're not educated, you don't have any information to negate something that someone's telling you. So when you work early on with a client, it gives you a really good starting ground to start that education piece. Once you go from education, then you can lean into advocacy. I think that one of the main things that I do with clients is, well, if you went to a restaurant and you asked for a sandwich and you got a salad, wouldn't you send that back? And that kind of makes things a little bit more real for them, because people don't think about that when they go into a hospital. They're like, I am sick, or I have a need, or I'm getting ready to have a baby, and so I have to do what they tell me. But it is a service. It is a service that you go to because you have an issue and you need support. And so when you educate people about all their rights in those regards, it changes how they engage with their health care. It changes how they ask questions at an appointment. It changes how they say, oh, hold up, you're not about to give me that because I told you I don't want an epidural. It changes their active engagement with their care. And I think that you can't advocate well if you aren't educated well. Yep.
Okay. First and foremost, thank you for the introduction. However, it's the Black Maternal Health Fair. So off this question, I would definitely sit there and say, Marquita, you asked right about the education piece. However, some doulas are not fortunate enough to sit there and work with a mom early on. So I would have to say that education is very important, but also understanding their learning style. Understanding like where they are on the education level, because a lot of, on an average, a lot of people are reading or understanding on a 4th grade level. So if they are not educationally equipped to understand what is going on, then how can they actually advocate for themselves? So basically, prepping them in a way that they not only understand, but they can sit there and talk in their own language. So when a doctor do say something to them, they can say, no, hold on, I'm not really comfortable understanding what you're saying. Can you explain in a different way? That's my spill.
So I feel like everybody sort of covered everything. As an OBGYN, I will say that I think that sort of these tools are really important. Understanding, that on the other side of things, like, we're tasked to see however many people in a day, and that's usually coming from above and all of those things. So I think slowing down the appointment is a good way to just sort of be like, hold up, and because we're so used to being like, go, go, go. And so if people aren't asking questions, we just assume there aren't any. And so I think like making sure, like writing down the questions ahead of time, I think, and slowing down that appointment and making sure that you sort of take a pause, which I understand is pretty hard to do when you're maybe in an uncomfortable situation to begin with. But I think like having the questions written down in a way that you understand what the questions are and you might understand what kinds of answers people might give you is a good way to at least start that conversation. And just even asking in the appointment, like if your questions aren't being answered, what's the next way I can come and talk to you, because I just really want to talk about specific things, like what can we expect the next time, or can we have a separate appointment where I really just sit down with you and talk and ask questions, or what's the how can I get in touch with the nurse in the office to ask more questions. So there's other ways that you can engage with the healthcare provider outside of the office visit, and it might be a way that's more comfortable for you if it's on the phone or whatever, but there are other opportunities to be able to talk with people, and that may not feel as rushed, or you might not feel as intimidated if you're in a situation where you're not feeling comfortable with the provider. So I think those are just sort of other tools that people can use.
And I have one follow-up question. Like Jaleesa mentioned that sometimes providers won't trust the information you bring. So you bring a person or a picture or you're writing questions down. But if you could think about how can providers be better advocates for their patients and what can you do to speak up for your patients?
All I was going to say is that providers have to listen, and I feel like people say this over and over to nausea, but like that's exactly what has to happen. Like you have to be able to take the time out of your appointments as a provider and really listen to what your client is saying. Mm-hmm. Not as they're talking, you making a diagnosis in your head, because that's 9 times out of 10, not every physician, but a lot of doctors do that. And so what I need you as a provider to do is when I'm there with you to be present here with me, so that you can actually receive the things that I'm saying to you.
So, I come from a really sort of like higher level policy background and thinking about, not just the one interaction with a patient and a provider. So thinking about sort of globally how we can sort of change the landscape of healthcare, not just in maternal health, but in all aspects. Like, in medical school, that's exactly how we're trained, is to listen to what people say and come up with a differential diagnosis. That's just how you are educated. And so thinking about putting, different parts of that into medical education, so you're starting from the beginning, because that's how people learn and that's how people become, practitioners. And so, automatically you're siloing yourself or speaking a different language than what maybe what society needs, what people need. And so I think from like a larger scale is about sort of how do we integrate all of this to begin with in medical education, so that way it sort of is down the line, like not something that you have to like intervene in individual ways, but it's more in a global landscape. So I think that's sort of one of the first things that we can do as for ourselves and for our education, is to include some of those types of pieces in medical education. Other things that you can do on the day-to-day basis about advocating for your patients is to also think about yourselves and how you're contributing to the potential disconnect between being a provider and working with women, working with individuals in their healthcare. And so, I know Representative Cephas had spoken about implicit bias training and making that mandatory for clinical or for people that get their state license in Pennsylvania. So that's one way. But, I think implicit bias training is important, but it's not just a one-time type of thing, right? So it's like not like, oh, you're cured after your 2-day session getting implicit bias training, right? Like it needs to be sort of an ongoing thing, and it needs to be sort of thought about and talked about, in the halls and in the hallway, and like, keeping those types of things consistent in every aspect of a hospital system or a healthcare system. So, implicit bias training is good and it's a place to start, but how do we think about that long term, and how do we, because that's the only way you're going to have like long-term change and a real understanding of all the biases that a potential encounter could have.
So it sounds like you're talking a little bit more about like that training being like a tool. What are some of the other tools? I heard some of you mention tools. There's I know specifically, Marquis, you were working on a work group bill of rights for patients. I know, Jaleesa, you can think about some of the tools for advocating for breastfeeding for yourself, and then, doula support as a tool. Can each one of you speak a little bit to some of those tools?
In addition to some of the work that I do with the Department of Health, I'm also a co-chair for the Philadelphia Breastfeeding Task Force with the very close to me Maternity Care Coalition's Naima Black, and it's a coalition where providers, but even community members can come together and discuss things, like trying to understand from different perspectives and having conversations where what exactly is going on. Like, these are providers, these are women who are breastfeeding, what exactly is the root issue? And not just looking at what we think, you know, like going back to the community, going back to have conversations and asking questions to clients and patients and mothers about what are the barriers and, you know, what are, like, what's really going on. Not what we think is going on, but truly seeing if we can understand if there's a trend, if they're, you know, surveying, having focus groups, and really getting information that we can hopefully use to influence program implementation or tools. Because if there's a toolkit and it's not addressing the needs, it's not really a tool. So,
I would add to invite those providers into our space. Like, I know when Crystal and I were thinking of who to invite for the Black Maternal Health Fair, we invited some of those providers. We invited some of those OBGYNs and different midwives from different hospitals. So I think inviting them in, and also even like, I'm super extra, so whenever I go to a doctor's appointment, or if it's for me or a client or anything, I'm always talking about Black maternal health. I'm always talking about the rates and the statistics because everyone loves numbers. So I just feel like whenever you in a space with someone, just educate them because they may or may not know.
Marquis, did you want to add about the workers, but the access to the work groups Bill of Rights?
So in the CAN, I helped to put together a Bill of Rights and Responsibilities. But at first it was like, hey, we have this Bill of Rights to help patients navigate their own care. And I had brought up that we can't just tell patients they have rights without requiring providers to have responsibilities. Like, those two things come together. So I think that, I mean, I don't have it all on the top of my head to like write it out to you, but the CAN has access to the Bill of Rights. It has to correspond with the two parties in the relationship. And so a lot of times clients are being told, you have to do this, you have to do this, you have to do that. But if you're walking into an environment that's inhospitable for you to have your rights met, then without these other responsibilities of the providers, there's a disconnect and you will not have your goals accomplished. And so I thought it was really important to put some responsibility on the providers too, and not it just to be based on the patients.
And I know, Candace, you mentioned briefly about Black Maternal Health Fair. How is it or can be a tool for healing that empowers Black birthing people? Can you just, this is your opportunity to like...
Oh, to shine?
Yep, to shine.
So, on the resource table that you guys have, the Black Maternal Health Fair flyer is out there. So it's April 11th from 10 to 3, which is a Saturday. It's the first day of Black Maternal Week. So the health fair. Last year we did it at King Sesson Rec Center, and if anybody was there, they know that it was super hot. But however, even though it was hot, we had 150 people attend, and it was a great turnout. A lot of people talked about, you know, the women that was there, and some of the men that was there as well. They definitely discussed how we were able to come together and get a lot of agencies and organizations to come out and discuss what they do. Last year, oh my goodness, we had so many people come out, just talk about their services and how they were able to help. We had everyone from the School District of Philadelphia Teen Elect program to talk about their teen parenting. We had midwives come out, and it was a huge thing, and it was a very quick thing that we did, but it was an amazing because we saw the need in our community, and we were able to, once like you talked about the education piece, not only were we able to educate them, we were able to provide them with resources, and we were able to provide them that power to advocate for themselves. So once they left, they felt powerful to go back to their doctors. They felt powerful to go back to their communities, to their sisters, their aunts, their uncles, and talk about different things from breastfeeding to comfort measures to healing birth trauma is serious. So this year, we have a bigger space thanks to Temple. And we have a whole lot more to share. So we have about 10 workshops that we are doing. Everything from talking about birth trauma to comfort measures, breastfeeding, epidurals, infant care. We have a lot of different agencies coming out. So please share. I will be in different neighborhoods just passing out flyers like I am the census this year. So, yeah, so it's going to be great. And our mission is to continue to increase the number of people that come out from the community and also increase the number of people that feel powerful to advocate for themselves with the proper education and knowledge.
So I think we have time for one audience question, and while that's generated, I wanted to just do one quick lightning round with the panelists. If you could just name one tool that you use for your own healing, and I'll let the audience ask one question before we break for lunch.
For my healing, I would definitely say is that I dance. I love to dance. My family's from the Caribbean, and all we do is dance.
I watch a lot of reality television.
This is going to sound real cliche, but I was really against it in the beginning. But I do meditate, but I'm very much not a kind of meditative, energetic kind of person. So for me, I was like, I can't sit there and be quiet and not think things. But it takes practice. I think it's definitely calmed myself, like my internal spirit in a way, that things that are happening externally don't affect me in the same way. And I think that that's a huge part of my healing as a birth worker in particular, because a lot of things that are not in you are happening around you, and you have to carry a lot of that.
Yes.
So I would say that's my biggest tool.
I also meditate too, but I think probably one of the biggest things that has been helpful for my healing is staying moving. I think like doing yoga, especially with my kids, so it's improv, it's not traditional yoga. But which brings a lot of laughter and things like that, but just being and keeping moving is something that when you're bogged down with stress or with frustrations or time limits, make time. Because if you don't make time to move and be active, your body in different ways will kind of show you that you need to be still. And sometimes what you really need to do is the opposite.
My kids and I also practice improv yoga, so I feel that. And yeah, moving is important. We have a question?
I was a midwife for 20 years. I delivered about 2,000 babies.
Yeah.
And a psychiatric nurse practitioner now. And one of the things that really struck me in my practice is that when women come into appointments and they're in a patient gown, that it really creates a hierarchy. And so I'd like to hear your thoughts on that, but one of the things that was important to me was that when I saw patients and I wanted to have them voice what their concerns were, that it was important that they were dressed first. Yes. And so when women advocate that they want to be dressed in order to talk, because for me, also having a history of sexual trauma in my life, that coming into that situation in a hierarchy, not being able to be dressed and being able to advocate for yourself, it just makes it so much harder.
I think that that being undressed factor is really big, but I also think that particularly when you're talking about African American populations, you're dealing with white coat syndrome. And so just simply going to the doctors causes trauma. Having to make an appointment and figure out why your hip hurts is causing trauma. Because you don't know when you get there what is going to happen or what they're going to give you and what that will do to you. It's like a cycle. So I feel like we really, this goes back to the healing conversation. There's a lot of historical, excuse my French, shit that's, piled up in that issue. I don't think it's necessarily about being clothed or not clothed. I think that if you had your clothes on and you know that at some point you have to take your clothes off to go see the gynecologist, it's going to render that same level of trauma. So I feel like that's a way bigger question than what we have time for, because how do we destroy the traumatic effects of slavery? Like how do we do that? And I feel like that's a consistent issue, and you can't really address that until you address the core issue.
Candace?
Yes, I definitely want to piggyback off what you said. It's definitely a lot of healing that needs to be done. As a social worker and that studies trauma, there's trauma everywhere. And there's definitely a power struggle when it comes to when a person sits in a room and the other person is more economically higher than that person or more educationally developed than the other one. So I think, you know, we can sit there and pinpoint like, oh, well, you have your clothes off, now you should be belittled. No, that's not the case. The case is that each individual as a human being on this earth should look at their own biases and their own power struggles and see where is the gap in between that. Like, if I sit in a room with someone, I'm not going to sit there and say, well, because I'm a social worker and I have a higher education than you, then I'm better than you. I'm not. There has to be a groundbreaking line where our society has to see their mistakes, and they don't. We see a quick fix, and we see that because that person has a degree, they are better than us. But I can sit there and tell you that now, each person that I assist has a doula, no matter if they're 13 or the age of 34, they have more experience than I will ever have, because that's their own individual self. And no matter how much education or reading I do, I cannot sit and tell someone what they can or cannot do.
And I want to just piggyback off of what Candace said. A lot of providers forget that the health and wellness piece is a collective effort. So when you have a patient, a lot of times providers will take a stance that they are the expert, and they need to shed that. They need to take that bias and remove it so that they're approaching their patients and their clients in a manner where they feel like this is a collective, and this is something that, health and care is not happening to you. It's something that we're doing together, and I think once we can move providers to doing that, we can hopefully get patients to be able to bring their unique backstories and their backgrounds and their traumas and things that make them comfortable and uncomfortable to the table to be addressed and to be spoken on, and not to feel small, whether they have their clothes on or not. And I do think that you trying to do that is something that probably has made a difference for some patients. But, like Marquita said, that sometimes it's not going to be enough, and there is so much trauma. There is so much unhealed or unspoken things. And also as a provider, asking consent. I think a lot of providers have a lot of patients who may be non-compliant, and it's not that they're not compliant, it's they don't feel comfortable. They don't feel that they connect, and if you can literally take that power dynamic and say, is it okay if, are you comfortable with removing or changing, or we may need to do this, and allowing them to give consent, that can be something that can shift that power dynamic where the power is in their choice to make that decision.
Thank you so much. That is, yes. Give the ladies a round of applause. Thanks for your question. And I just wanted to echo Jaleesa, because you sort of just transitioned very beautifully to the part that like healing doesn't have to happen alone and shouldn't happen alone. It's a collective effort, and everyone has a role and a responsibility to be an actor or an agent in that healing process, whether the trauma is something that you've experienced or the trauma is something that you've triggered in someone else to experience. And so we each have a role, and we need to continue to center the person that's living that experience and their voices. And so thank you for your powerful words. We are ready to break for lunch. I'm going to pass it right over to Pam. Thanks so much, ladies, for your perspectives.
Y'all don't have to sit there awkwardly if you don't want to. I mean, if you want them to continue to see your faces and get some, hey, yeah, experts, because experts, right? I just wanted to offer some follow-up reading for what they were talking about. There is a book called Post-Traumatic Slave Syndrome. If you've not heard about this, it's by Dr. Joy DeGruy. And yes, it's some powerful stuff. If you're not a book reader, or if you're a book skimmer, or if you're just a YouTuber, you can find her on YouTube. Again, Dr. Joy DeGruy. There's like a 1 hour plus video of her like giving a lecture. What she says in that video is that she takes a whole semester and packs of a master's level class and packs it into an hour. It's a lot of information. For me, it was really healing. For some, it may be some difficult information to process, but I think that it will get you into the right mindset to, thank you, Jabina, to really process this information, digest it, and think about how in your practice to consider intersectionality as a priority, and why we need to heal from 400, 500, 600 to today years of slavery. I could go on and on about that. That's not my job today. So we're going to go eat lunch. Lunch is in the lobby. There's also the collaboratory room if you need to chill. Drexel really doesn't want us to take food in there. FYI. And get to know some new people. All right, we'll see you at 1:15-ish. Welcome back. Welcome back, welcome back to Advancing the Village. Everybody have a good lunch? Yeah. Did everybody have a okay lunch? So as we get settled back in, let's do a little activity. So I know I get the itis when I got a little food in my belly. So if you're able, please stand. If not, you could do this from your seat. So please rise. Do one at a church. All rise. Okay. Now, you might remember this song. Maybe you're singing this song to somebody presently, but let's do it together. Head, shoulders, knees and toes, knees and toes. Head, shoulders, knees and toes, knees and toes. Eyes and ears and mouth and nose. Head, shoulders, knees and toes, knees and toes. Yay! Good job, good job. So before we bring up our next facilitator, artiste, I want to recognize 3 organizations that have been awarded funds, because we know funding is a key and essential measure to change because we live in a capitalist society. So fight capitalism with capitalism, I guess. So these funds have been awarded through the Philadelphia Community Action Network. These 3 organizations are piloting or enhancing services that support the vision of the CAN's Integrated Care Work Group, which is to promote awareness about the importance of behavioral health services during pregnancy and connecting pregnant women and new moms in Philadelphia to behavioral health resources. Right? Okay. So, without further ado, let's give out some awards. Okay. The first award goes to, well, there's no drum roll. They know. They got it. They already know. But let's do it for the sake of this event. Inner Circle Midwifery. Yeah. Come on down. You're the next contestant on Get This Grant Money. Thank you. Okay. That is her speech. Okay. The next award of recipient of the CAN Opportunity Grant, you feel me? Okay. Is Maternal Wellness Village. If all y'all in the house, come get this money. Come get this award. Do y'all want to say anything? Thank you. Okay, all right. Okay, and last but certainly not least, the next recipient of the CAN Opportunity Grant Award is Birth Brown. And so they got this money, y'all, which is a huge deal for smaller organizations, the grassroots, boots on the ground, working with the mommies. Did you want to say it? No, thanks. So give it up for these amazing women doing amazing things. Do some great, well, I know y'all gonna do some great stuff with this money, but yes, thank you. All right. That was fun. I really wanted to give them big checks, but that just wasn't feasible. And flowers looks nicer. Oh, word? You do? Oh, the baby? Oh, yeah. Okay. All right. So, okay. Okay, I want to introduce Nikki Brake Sela, who is a fellow Leeway Art and Change Grant awardee. Speaking about getting that money, Nikki Brake Sela is a Southern to her core with a Northern patina and proudly calls Southwest Philadelphia home. She recently received her bachelor's degree from the University of Pennsylvania, okay, Ivy League, and MFA from the City College of New York. Ms. Brake Sela is a recipient of the 2019 Mitten Lab Residency and the Leeway Foundation Art and Change Grant. She is the founder of Dramatists at War, and an inaugural member of Josca Playworks. She has received funding from the Leeway Foundation, Playpen, Philadelphia Independent Film and Video Association, the Princess Grace Foundation, the National Board of Review, the Bert Saperstein Foundation, the Institution for Humane Studies, the Danielle and Larry Nyman Family, and Public Media Foundation, and viewers like you. All righty, come on up.
Hi, thank you so much for taking the time out of your day to come. The monologue that's going to be performed is my life. It was my week in the NICU here at the University of Pennsylvania Hospital with my now 3.5-year-old daughter. It's called AMA, Against Medical Advice, and it will be performed by my incredibly talented actress, Victoria Aaliyah Goines. And I would like to take this time to hold space for a mother who lost her life on Tuesday. My friend Hans lost his sister and business partner. She leaves behind a 6-year-old and her newborn daughter, and her name is Cordell Street. So I would really like to take this moment and use this to hold space for her and for her family and those that she loved and left behind. It's 2020, y'all. It's 2020. And we're out here dying. So I really, really need to see that change. All right? Thank you.
Hi, everyone. My name is Victoria Goins. So typically, I'm so used to performing in like a theatrical space, and we're in a lecture hall. So I'm going to need a little bit of assistance so that this is super duper clear. The first thing I need you to do is I need you to use the power of your imagination and imagine that this is a NICU and this is our baby. And now I need a couple volunteers. I need a nurse. You don't have to say anything. You literally get to sit in your seat. It's just so I can have people to talk to, because we talk to like 6 different folks in this, and everybody's role is equally important. So I just want to make sure that everyone knows who I'm talking to. So I've got some fun little name tags here. If anybody would like to be or is a lactation consultant, anyone want to volunteer? Thank you so much. Thank you kindly. Anyone want to be a doctor? Yes. Yes. And a nurse. Ooh, all in the front. And I've got 2 folks who have names. One is a fellow parent in yes, thank you. This is Miss Jakarta is your character name. And anybody want to be another NICU parent? I saw you first. Here we go. Thank you. Thanks so much. You don't have to stand. You don't have to do anything. It's just so that we know that we have our lactation consultant, our doctor, our nurse, who is costumed, for those of you in the back who cannot see. And then we have our friend, Jakarta, and we have another mom, Bethany, right in here. Thank you so much for your participation. I sing the same song to my baby girl every day. This little piggy went to market. This little piggy stayed home. This little piggy had roast beef. This little piggy had none. This little piggy cried, wee, 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 all the way home. Look at those perfect piggies. I could just eat them up. I could stare at them all day. Guess what? I will bite them and kiss them and be there for every celebration and boo-boo. I know the world seems like nothing but boo-boos right now. First day in your short little life, and it's already punctuated with pain. We just got to get through this. We're only going to be in here for 3 nights. Well, not that you know your days from your nights yet, so you'll just have to trust me. But then we'll head home together. How does that sound? Good? Good. Now, let's go on a walk and get a lay of the land. I just have to figure out how to get these wires untangled. Oh. These alarms put up such a racket. Don't worry, baby girl. I got this. I am on it. Excuse me, nurse. I can't really seem to figure out how to get these wires untangled. Oh, you were just about to check her blood. Well, do you have to right now? She's going to be so upset. I just nursed her, and I know. Do you know when the doctors will be by? Oh, well, I'm just concerned about her maintaining her sugar because my breast milk hasn't come in yet. Oh, they've already stopped by. But no one came to get me. I was in my room. I see. Well, will you please make sure you call me the next time they stop by? I really don't want to miss them again. No, I can hold her. Shh. Oh. All right. Shh, just a prick. Then, shh, all gone. Kiss, all better. What was her reading? Okay, great. So she's above 50, and next reading's in 4 hours. Her reading has to be above 60. No, but all the literature says that readings above 50 are indicative of, yeah, I understand hospital policy. No, I also understand how serious this is. I didn't want her on the dextrose initially because I was worried about her self-regulating. No, I'm not interested in formula. Besides, the 2 milliliters that you gave her when she was just hours old did nothing to keep her levels elevated. So I'll just keep nursing and pumping until my milk comes in. Yeah, I'm aware it takes a little bit longer after a C-section. I'm meeting with the lactation consultant today, too. Are you sure you'll call me when the doctor stops by? Okay. Yes, no, I know how serious this is, and thank you. Let's get back to our tour. That over there, well, there is Lathan. He's so beautiful. Skin like roasted cashews. His mama's name is Jakarta. She never only leaves the side to pump, and she brings over so much milk. Speaking of milk, God, you have quite the little appetite, Missy.
Well, it's time for bed. I'll be back to see you first thing in the morning. Hey, girl. How are you? Yeah, I don't know. It's weird over here. Only 2 of the nurses talk to the babies. 2. Yeah. Well, no, 3, technically, if you count the woman who only opens her mouth to fuss at the little chocolate drop who has acid reflux. What? It's not like the baby wants to get a taste of her food just to spit it back up again. I know, right? Apparently. The doctors only make rounds when I'm either pooping or nursing. Yeah, well, we'll see. You know, I just feel like if you work in a neonatal intensive care unit, you should probably poop rainbows and unicorns every single day. No, seriously, you deal with people at their absolute worst. We're scared. We've waited so long to meet our carbon copies just to find out that something's wrong. Yeah. Wait, hold on. Somebody's knocking. Hold on. Come in. Girl, I gotta call you back. The lactation consultant is here. Yep. I love you too. Okay. All right. Yes, I promise I will get rest. Okay. Bye-bye. Hi. She is, isn't she? I know I'm biased, but she's a keeper. How am I doing? Well, I'm stressed. I'm tired. I pump as soon as she's done nursing, and then as soon as that's over, she's ready to feed again. I just don't know how much more of this my body can take. Why isn't she getting donor milk? She can have donor milk? In the NICU. For free. And then I can sleep. Why didn't anybody tell me? I've been doing this for 4 days. Can we have donor milk when she goes home? Only in the hospital, but there's got to be milk banks or something. Thank you. I will look into that. I could literally kiss you. Thank you so much. Yeah, her sugars have just been all over the place. Yeah, tell me not to get anxious. I know. I promise I will get rest. I'll be counting all the sheep as soon as you leave. Thank you. Good morning, stink bug. How'd you sleep? You didn't keep your neighbors up, did you? Of course you didn't. All right, let's get back to our tour. Your closest neighbor is Mark, and this is his mama, Bethany. I know. Hi. How you doing? Hi, Bethany. How are you? Well, she is having trouble regulating her sugar. She has to stay above 60 for at least 24 hours in order to be able to go home. But she gets so close, her last reading will be like 55, and then she has to start all the way over again. How long for you? Oh, I'm so sorry to hear that. I've only been doing this for 4 days, and I'm ready to crawl out of my skin. 4 months, I would be ready to... Here's hoping that there's good news for you and your family soon. No, don't worry, we'll keep him company while you're gone. God, I feel like an imposter. Sitting here with you in the NICU with all these other babies who are really sick.
God, you were damn near 9 pounds, full term. It's all over their faces. What are we doing here? I don't feel right saying how I cry myself to sleep most nights when I manage to sleep from the sadness of this place. Like, how can I share this space, knowing we're leaving, feeling like we don't belong, and the whole time there's this dread creeping up the back of my neck? Oh, look. Lathan is breathing on his own. I know his mama must be so happy. Hold on, baby. Hold on. Don't cry. Do not cry. Do not cry. You are doing exactly what you are supposed to be doing. Fighting for your child, no matter what, exactly what you are supposed to be doing. I know. I got you. They're going to give him some oxygen through a piece of plastic. It's not going to hurt him. Yeah, I'm Dana. You're Jakarta, right? And your little cub, Lathan? I can see he has your strength. Now listen. Wipe your face. Breathe. And don't ever think that you aren't the best advocate for your child. Don't let them drain you. Good morning, doctor. Is it? No, I'm not doing well, not well at all. I've been sleeping in the NICU, which is a horrible place to recover after a C-section less than 5 days ago. I laid there on what was the pull-out bed in the family room, and the intake clerk is the one who had to tell me that there is a room here that I could have signed up for sleep, in a bed, instead of upright, which I've been doing, as I said. No, I'm not finished. You know the bed where I laid down after abdominal surgery. It took me almost 15 minutes to get up. I laid there, no way to reach my phone, no way to call for help. The whole time, I can hear my baby crying right down the hall. And when I finally arrived, I witnessed the most egregious act of humanity I could have ever witnessed. And I'm from the South, so I've seen some stuff. Oh, you're sorry. Well, you should be. Do you know many nurses walked past that mother who was literally breaking right in front of me? All because none of the doctors that rounded this morning wanted to tell her that the cannula being placed in her son didn't mean that he was going to have a breathing tube right down her neck. No one offered her any comfort or shred of dignity, like we didn't even exist. Yeah, I've already spoken to an attorney, and I'm going to AMA my daughter. No, I've been here for 5 days and 4 nights. I see how you treat the mothers who can't advocate for themselves. How am I supposed to trust that you have my child's best interest in mind when every single doctor that rounded this morning left a woman sobbing? As I've said, I'm going to AMA my daughter. Well, what do you mean I can't? She's mine. I'm going to take her with me. She's a ward of the state while being cared for. Even though y'all are doing a half-assed job of taking care of her, I'm going to be the one who endangers my child. Yeah, that's funny. You know who's really a danger to her? It's the nurses who look at her as an afterthought. They didn't even tell me that I could use donor milk. And during my exit interview, one of them kept asking me my WIC status. Yeah, you heard me. My WIC status. Asking me for my status under the rouse that it's to get Similac vouchers. She knew that I had just paid $400 for donor milk, but she couldn't use the context clues to know that I wasn't going to formula feed my baby. Yes, I'm breastfeeding. Yes, I know she drinks 2 ounces of milk at every feeding at just 5 days old. I wonder why. Where am I getting the milk? The same bank the NICU uses. But that's the information I had to find out. And when I suggested this bank, you all had the audacity to tell me that it wasn't a reputable source. Yeah. You should have seen her face when I told her it's the same bank you already use. You. 1 out of 5. 1 out of 5 people stopped to tell this mother, I know what you're going through, and I'll do everything in my power to make sure that your son is well taken care of. Yeah, I'm going to AMA my daughter out of here because, doctor, I'm tired. I'm tired of hearing her scream every time her heel is pricked. Tired of them having to run another IV because the veins in her hand have already dried up. I'm tired of having to stalk you before having any type of prognosis on when she's going home. I've done the math. If she fails this next test, she won't be home in time for her 7-day naming ceremony. Missing that is not an option. So you're going to have to give me some viable options or else I'm going to have to... Dextrose. Continuous drip. And so long as she keeps eating, her body should self-regulate. Well, it would have been really nice to know my options from the beginning. Yeah, I'm sure I will see you soon, since now you finally see me. Baby girl, life is full of battles. I pray that when you're older, those battles will be a choice and not a necessity. Thank you all so much for your time. Whew. I cried. You get me every time. I'm like holding on to my baby, like, whoo. You know? It's really like that out there, man. Or worse. Or worse, yes. Whew. Okay, so it was emotional for me. So we need to shake some body parts. Let's shake some body parts. You shake some body parts. Let's shake some body parts. You can go and play with the baby now if you want to. You want to go play with the baby? Yeah, she AMA'd her out of the hospital, so you can take her. That's right. Yeah. You hold the baby. Yeah, she's a good, you give her a hug. We'll take this show on the road one day. So for our next session, we have 2 presenters. And I just want to say some nice things about Jabina real quick. Because my breastfeeding journey would not been the same without Jabina. I'm getting emotional again, you guys. Oh my God. Don't fault me if I cry, because this is a mental health conference, right? So let's feel our feelings. My mom passed away. She breastfed me. So I didn't have any support in my family for breastfeeding. But Jabina hosts Bay Cafe at the library near me. And I was able to get that support
I was able to learn, because it's tough. It's tough. Like you heard in that play, it could be very difficult when you first start breastfeeding. It's difficult to say, oh my God, am I really going to do this? This hurts a little bit. You keep crying. Oh my God, am I feeding you right? But having that actual knowledge, the group setting where I could talk to other women who are going through the exact same thing and saying, okay, this is normal. I'm doing this right. I'm feeding my kid. Anyway, thank you so much for that, Jabina. Thank you. Anyway, let me tell you about Jabina's education. Jabina is a licensed social worker and international board certified lactation consultant who has dedicated over a decade of her life to serving women, children, and families in Philadelphia and surrounding counties. Ms. Coleman received a Bachelor's of Science in Biobehavioral Health, from the Pennsylvania State University and a master's degree in social work from the University of Pennsylvania School of Social Policy and Practice. Ms. Coleman is the owner of Lifehouse Lactation and Perinatal Services, LLC, where she provides in-home lactation consultant services and psychotherapy to parents experiencing perinatal mood and anxiety disorders. Ms. Coleman is also the co-founder of Perinatal Mental Health Alliance for People of Color, where the mission is to support professionals and communities of color who are treating and dealing with the complications of perinatal mood disorders. Jabina is the co-founder of Breastfeeding Awareness and Empowerment, BAE, a grassroots organization created in response to the public outcry surrounding adverse perinatal health outcomes for Black families in the United States. We're also introducing Ms. Salima McNeil, who's doing dope stuff in the community as well. Salima is a reproductive psychotherapist who completed her master's degree at Chestnut Hill College in the counseling and psychology program with a concentration in marriage and family therapy. As a traumatic birth survivor, trained doula, and certified lactation consultant, Ms. McNeil has dedicated her work to helping families of color heal from traumatic birth experiencing and transitioning to parenthood. Through her efforts, she founded a nonprofit organization, Oshun Family Center, and launched a citywide initiative to reduce Black maternal mortality with the Maternal Wellness Village. Let's same thing, yeah. Surviving the fourth trimester can mean life or death. Therefore, Salima's work is grounded in helping those families not only survive, but thrive. Give it up for these two ladies.
This is y'all? Yeah. Okay, cool. Move. Oh, it's up there, but you guys don't have presenter view. Okay. Oh, yeah. Cool.
All right. So good afternoon, everyone. It is actually really hard for me to actually come up here after the monologue because a lot of what was shared, what was demonstrated really hits home, not for just myself, but I know for many of the folks that I interact with and I encounter. So for me, I just need to take a moment to just sit with and acknowledge those feelings.
and for any of you that need to do the same. I want to acknowledge those feelings because those feelings are real. And I want to acknowledge Pam for actually being one of the very first participants at Bay Cafe. And when I met Pam, Pam was 41 weeks pregnant. And so I was able to see Jimmy, AKA James, right, transition and grow. And a lot of the work that we'll talk about is surviving the 4th trimester. And the work that I do in that 4th trimester is so that we can have experiences, so that we can see, and that folks can have support in that 4th trimester that is meaningful, that holds space for them, that acknowledge who they are, and to validate their experiences and feelings, in spite of what they may experience in the hospital setting. I have the opportunity to do that work in the hospital setting, but I chose not to, because my work lies within the community and with the folks that I know need that support after that in the 4th trimester. So on that, I am honored to be here. I'm honored to hold space with you all and to share and talk about maternal mental health, specifically Black maternal mental health. Thriving in the 4th trimester, awareness, education, and change. We're moving forward with advocacy and action.
Thank you. Good afternoon, everyone. We have been anticipating coming up here all day and just so excited to share with you all what we have been working on and informing you more on how to survive or help people survive the 4th trimester with a collection of services, village, and support. So the Maternal Wellness Village, the mission of the village is to function as an action-oriented task force. Throughout the years, learning more about maternal mental health and maternal and infant mortality in Black communities, we realized y'all know what's going on. So now it's time to do something about it. And how can we dispel functioning in silos and come together to form a mighty task force that can work in an action-oriented manner to help combat those issues that are plaguing our community? So we are providing services that empower communities throughout the African diaspora, so all our Black folks, women of color. Through our efforts, we aim to increase modern adaptations of ancestral birth practices, reclaim the Black birth experience, and reduce Black maternal mortality. Black on Black on Black. Because we are impacted at a greater rate than our counterparts. And so that's why this is so important to know and understand what we face on an everyday basis going into healthcare systems that were not originally geared to treat us well. So, to all my healthcare professionals, listen with an open heart and an open mind. We're going to take you on a journey because, as you heard, I am a survivor and I am here and I have a story to tell, just like a lot of women in this room right now and many of women in our community outside. So today our objectives are to educate you all on surviving the 4th trimester, increasing awareness of perinatal mood and anxiety disorders, which is not just postpartum depression. And we have an ask of you all. We will be charging you all to become action-oriented with us as well and rally with us to help make this permanent change. Oh. That didn't happen. Yeah. You gotta love tech stuff. It works perfectly until you're up here and then it doesn't want to do that anymore. So I'll tell you, the next slide is about the Maternal Wellness Village. Shout out to everybody in the village. Look at these beautiful women. Oh my God.
Is that okay?
Yeah.
So,
It's doing it, yeah.
throughout this journey, all of the women that you see up here, we have worked together in some capacity, whether it was planning an event, doing a workshop, consulting with each other about lactation or birth, and so forth throughout preconception through postpartum. So the Maternal Wellness Village functions under my organization, Oshun Family Center. We are a registered nonprofit. I'll start here. So we have Miss Selena Washington, who is one of a handful of Black reproductive psychotherapists in the city who are now providing individual services to families that are transitioning into parenthood. You have Sabrina Keaton next to her, who is the owner of Queens United Holistic Health, who does natural remedies, Reiki healing. You have Raina Hughes, who is our administrator that helps keep everything that we need in order. Portia Holland, who is in the room today, who is not only one of our resident doulas, but she helps to organize our volunteers and one of the organizers for the Black Doula Meetup. Then you have Shakria Mitchell-Hinton, who is a nurse at Nurse Family Partnerships and has worked with us tremendously. This is myself, and then Deanna Murray, who is our graphic designer, and she is the owner of Barren Fruit and Deanna Nicole Design, who also holds space for infertility healing at the Healing Oasis at the Discovery Center, and they will also have one during Black Maternal Health Week. We have Iris Kimbrough, who is another doula that we work with, who also does workshops, breastfeeding education, and loves healing through trauma. Jabina Coleman, who is my good girlfriend up here. And last but certainly not least, we have Takara Gainey, who is another one of our doulas, placenta encapsulators, and childbirth educators. Yes. So we are a village of therapists, doulas, lactation consultants, holistic healers, infertility warriors, and nurses combined. We have multiple levels of education and experiences and over 50 years of parenting skills. Our kids they're here, they're thriving, they're alive, but we have struggled through some phases to get them where they are today, and we lean and use and encourage each other through those obstacles. 35 years of lactation support, from being CLCs to breastfeeding peer counselors to internationally board certified lactation consultants. In addition to that, we provide labor support for the over 25 years with doulas, and last but certainly not least, 10 years of mental health support. So one thing that you can see by looking at that list, one of the last things on there in the least amount of time is mental health support. So understanding and learning what it looks like to come and get therapy from someone who looks like you, to be in that experience and healing through your journey from someone sitting across to you that can relate to you, and not only, or if any, about your story, but just on your everyday struggle. I and other women are survivors of traumatic birth experiences and perinatal mood and anxiety disorders and infertility struggles. And last but certainly not least, we're survivors and we're mothers that have come together to make sure that other mothers in the city do not suffer some of the atrocities that we have within the healthcare system.
Where's Tech Guy?
Oh.
Call Tech Guy.
Cue Tech Guy. Come help us again. So what is the why behind our mission? Why do we do the work that we do? So the list here explains a little bit as to why we do the work that we do, but I am a mother of a 14-year-old giant. He is about 5'8". He stands a good 200 pounds, and his voice is probably deeper than the average 14-year-old. He sounds like a grown man, which gives me so much anxiety because I have to release my child into the world every day in hope that anybody who looks at him can see that this is a child and he is not a grown man. So almost 14 years ago, when I delivered, for all the medical professionals in the room, I was preeclamptic and my blood pressure was 202 over 153. And for everyone who doesn't know, that is in stroke range. And I had no clue what was happening to my body during those times when I was at the hospital, because it was very rushed. I was sent straight from the health center that I was going to with my folder and put in a cab and told to get straight to the hospital. So I did that, and once I got there, I remember feeling like I was standing on I-95 and just cars were just going past me, through me, and around me. But those were the doctors and the nurses that had realized that my blood pressure was so high that it was immediate action that needed to be taken. So I had one person on my bed trying to get an IV started, but I was so full of fluid that she couldn't get one, and she tried and tried again. They were rolling me down the hallway with a doctor named Dr. Momma. For anybody who knows, he used to be a very nice physician here in the city who is now in another state. But I actually thought that they were playing and trying to make me feel better when they told me his name was Dr. Momma. And I'm like, obviously that's not his real name. What OBGYN's name is Dr. Momma? But that was actually his name. And so going throughout that experience, it really was hard for me because it made me a statistic. I was what you call a near miss. And luckily, they missed because I'm still here. So the rates for Black maternal mortality is 27.4 births per 100,000 live births, and this is in Philadelphia. And so we look at these statistics, and it may seem low, but in comparison, that's 3 to 4 times higher than our white counterparts. And so a lot of what you heard today, systemic racism, oppression, implicit bias, different practices, are what goes into us not coming out. And that is something that needs to change. Black women are twice as likely to die within the first year of childbirth. And both maternal mortality and infant mortality is very high in the city, and it's a public health crisis. So when we look at things as a public health crisis, it puts a little fire under some of the people who make the decisions, hopefully, hospital administrators, lawmakers, legislators, to understand that this is a problem. And in order to rectify this problem, we need to take an approach that's not only from the top down, but from the bottom up. And so I will say that I am mildly pleased with some of the attention that the city and the Department of Health is giving to this issue, especially with the bill package that Morgan Cephas has introduced, because it is very much so indicative of a top-down, bottom-up approach. I love all of the doulas. I was a doula for almost over 10 years, and I practiced inside a Riverside Correctional Facility for part of that time as a doula. So understanding that doulas play such an intricate and important part in the health and wellness of Black women, but what we won't do is put the pressure on doulas to save Black moms, because that's not it. We can only function from both ways. You have to put the services from doulas and therapists and lactation support and nurses and community-based organizations that can all work together, because we all have a hand in a lot of these moms' lives, and we cannot do anything that will be sustainable if we don't work with universities who train med students, who train doctors, who put out those residents, if we're not working with the medical establishments to say and to train them as well. One implicit bias training is not going to change the world, but one implicit bias training per hospital in Philadelphia can start changing the minds of the people who make the decisions for us. The number of women who die in childbirth globally has fallen, but the rate in the U.S. has gone up. Why? Nationally, the maternal mortality rate is 44 to 47 deaths per 100,000 births, which is 3 to 4 times higher than our white counterparts. Every day in 2017, approximately 810 women died from preventable causes related to pregnancy and childbirth. And so when we look at numbers like that, they're staggering. And we don't live in a third world country. So what is happening in the United States of America that Black women are dying at such an astronomical rate? And I think the work that we've done here together has given you more insight as to what the causes are and how you can help to play a part in circumventing some of those issues. Dr. McLemore, Monica McLemore, who is a part of Black Mamas Matter, instead of patronizing Black women and blaming maternal health inequities on Black women, we must seek to understand the role of discrimination. Flat out. If you are not doing your work to understand, then you don't know your impact.
Let's try this. I don't know what's happening. He said every time.
I'm not sure why.
Yeah, we're up at this. We're slide 5.
Okay.
Don't touch this. Just hit there.
Don't
touch this. Yeah,
Don't
just hit it there.
So contributors to maternal health disparities: systemic racism, oppression, trauma, near misses, microaggressions, and medical assumptions. What could those medical assumptions be? Could the assumption be that black women can tolerate more pain than our white counterparts? I think it can. Later on, so had my son in 2006, I had to get an emergency appendectomy in 2015. I didn't really understand the full effect that my birth experience played on my life until that moment. I had some emotional struggles that I had to work through as well, but it wasn't until I had to get emergency surgery and I got whisked into the OR and it all came flooding back. The bright lights, the cold room, and understanding that there was an emergency, I said, y'all have to wheel me back out. We got to start over. And the doctors were like, why? And I'm like, I'm so triggered right now, you won't be able to get me to sleep. Wheel me back out into the hallway. And so they listened to me and took me out into the hallway. Now, before I get to this lovely hospital, I went to a hospital previously. And at that hospital, if anybody has ever had an appendectomy or appendix issues, it was worse than giving birth, honestly. And I get to the OR, I get to the ER, and the nurse says, on a scale 1 to 10, what is your pain? And I said, Miss, it is a 10. I am in so much pain right now. She said, okay, go have a seat in the waiting area. I was like, oh my gosh, I'm going to die out in the waiting area. I sat there for 2 hours, and no one ever came to check on me again. And I knew once the 2 stab victims came through the doors that they were never going to see me. And so I had given up at that time. I wanted to go home and go to sleep. I told my husband to take me home. I'm going to sleep it off. After I had already been in pain for a couple days. And luckily, he took me to the next hospital where they came in, checked, listened, and was very diligent about getting me to the hospital. So understanding what that trauma from my birth and how it impacted me later on in life really gave me a better understanding of how the residual effects of trauma impacts you throughout the years. And sometimes you don't understand how it will impact you, but once you get into certain situations and you're triggered, then you have a better understanding of what the toll it has taken emotionally and physically on your body. So luckily, they wheeled me back out, and I said, if you dim the lights and find the very nice lady who puts the fun stuff in your IV, then I'll be good. And they did that. They dimmed the lights. The lady came to give me something to take the edge off, and everything was successful. And that was the first time that I felt that someone listened to me, that they took the advice on my body and actually applied that to have a successful outcome. These are the things that our women are facing every single day, if not in society, definitely in healthcare. And so it's very hard to say, we're going to put this system in place and help you advocate for yourself when we all know that no matter how much psychoeducation you give somebody, there is something debilitating about sitting in a doctor's office, in a gown, in your clothes, one-on-one maybe with this person who is an expert that often makes you feel less than about your own body. And so it takes more from the top down. I did it. Listen, this is a major part of the solution. If I or anyone else goes to the doctor or the hospital, what we do know is that something's wrong. What we don't know is what's wrong. And that's what we are coming to you for. We don't know the diagnosis or what could be happening. We just know something is off, something doesn't feel right, something is not normal. And that's when we're coming to say, this is what I need help with. And if we're not being validated to say that your experiences matter and they're not diminished, it's very hard to full on get the care and the trust that needs to be established in order for me to do well as a patient. Listening to black women, listen, actively listen. That's what I should have put. Actively listen to black women. Actively listening means that you are listening with the intent to understand. You are not making your diagnosis. You are not figuring out if this person is poor or took a shower or what their education level is. It literally means that you are full on present and you are listening to what this woman has to say. Because when we deliver, that is a complete overhaul of your mind, your body, and your soul. And when we have postpartum hemorrhaging and we have emergency hysterectomies because we don't know what's going on, when we have C-sections that we don't have the slightest clue as to why this is occurring, that is not informed consent. Giving someone a piece of paper to sign is not informed consent. When we talked a little earlier, consent is understanding. And on our end as grassroots organizations and what we do with the village and will be doing with the village, because we got some funds, y'all, is making sure that we have given our clients the tools that they need to survive. Surviving the 4th trimester and having a village is important. So if you can stack your village, you have your doula, you have your lactation support, you have your mental health support, and your family and your physician or your midwife is understanding and willing to let all those people in, because sometimes medical professionals get very territorial and want to know who this person is, who that person is, and why they're there. It gives the understanding that we are together and that you will be held accountable when you don't show up the way you told us that you were going to show up. So not only listening, but being able to apply the things that you learn from the people that are sitting in front of you. So what does trauma-sensitive patient care look like? One, it looks like listening. So treat everyone as if they've been traumatized. Treat everyone with kindness and respect. And you don't need to be able to identify the trauma for you to treat them a certain way. Your trauma can be from a car accident, or your trauma can be from a natural disaster. Your trauma can be from a birth, or it can be from physical, mental, or sexual abuse in your life. What you don't need to know is those intricacies into that person's mental status to treat them accordingly. So if you treat them as if they're autonomous, as we are autonomous over our bodies, then it reduces the anxiety that we feel going to the doctors. I remember when I first had a physician explain to me what they were going to do. Okay, I need you to undress, and what I'm going to do is I'm going to check you for this, and I'm going to do this procedure or this testing for that, and this is why I'm doing these things, so we get a better understanding of you and what's going on. And I said, wow, you are so nice. And they looked at me like I was crazy. Like, why did I think that this physician was so nice? Because they explained to me what was actually going to happen. Because that's not the norm, and it should be. Check your biases. We all have them. There's no person sitting here or walking anywhere in the world that does not have a bias. Right now, the coronavirus is an issue, and we like to think that there is Asian people who are the most that are impacted, and society are treating them less than, when this is a global issue, people, and those types of biases would have you mean to someone else, disrespectful even more to someone else. So when we look at these things, you have to understand that your bias does not hide. You can't hide behind it, because when you say, oh, she doesn't need pain medication because she looks like she's tolerating well, and my white counterpart who is doubled over in pain can get the Dilaudid, it's like, why do I need these Tylenol 3s so I can sit there and still feel all the pain? I am a master's level clinician, and I will not utter a name of a medication and ask my doctor for it pain-wise in fear that they will think that I'm pill-seeking. Yes. I know pain medication. I've worked in a medical field for quite some time. I understand the impact, but I will not ask, because I don't want them to see me as if I'm pill-seeking and understanding the epidemic that has taken over that doesn't have anything to do with me, but I'm impacted. Patients are the experts of their body. Informed consent is more than signing papers. Eliminating blaming language. Non-compliant. Oh. I challenge that so much because if you have a bad attitude as a physician, then you don't check your bias, and then I'm non-compliant because I don't come to the visit because I don't want to see you. But our people don't feel empowered enough to say, you know what, I'm your boss, and you get paid because I come here, and I don't like this, therefore I don't have to see you. I don't. But unfortunately, we've been told that what's white is right, and it's not. And you have to understand that empowerment is making decisions. And when we get to empower our people, we give them a voice. And it's for you all to listen. Fear-based tactics. Anybody or a lot of people who have delivered children, if there was any high risk or decels in heart rate or oxygen, and you had to have an emergency C-section, 8.5 to 9 times out of 10, you were told that it was to save your baby's life. And that is the first decision that you get to make as a parent. And you are shamed if you question, you are shamed if you delay. And so using fear-based tactics, it's a form of medical manipulation. Thank you. I was thinking of a way more egregious word. Yeah, medical manipulation. And it doesn't give, it makes you feel so powerless. And if you go into the field thinking that I'm going to help people, but you're not going to empower people, then that's a wrong place to start. Because the first thing, hopefully, as a community-based organization, as a policymaker, as a medical professional, I will hope that it is your job to give people their voice and empower them to speak up for themselves. Because we don't need someone to speak up for us. And so understanding that last, but certainly not least, on being at least trauma sensitive. You don't get a whole 12-step trauma model and to incorporate. Just tap into your humanity. Get rid of late policies. Oh my gosh. I know everybody has somewhere to go. Truly understand it. I'm a therapist. At the top of every hour, I have somebody coming into my office. Time is money. So now that we got all those things out of the way, does anybody take public transportation? I'm pretty sure you'd be happy if your physician didn't have a late policy because you can leave an hour before an appointment and still be late. So can you imagine the frustration that you would experience knowing that you have properly left enough time for mishaps, that you left on time, that you were at the bus or the train station ready to get to your appointment, and you got there 15 minutes late and they said no? That's for people who have the means to possibly, okay, maybe if I'm running late, I could take an Uber. But if you don't have those options and you get to your appointment and your physician turns you away, that is so crushing, debilitating, and feeling powerless because you can get there 15 minutes late and your physician is already running an hour behind. So instead of playing those games, tap into the humanity to understand if this person isn't usually chronically late and you could fit them in somewhere else, then it will really be beneficial to make that work.
So we've talked a lot today about just different levels of advocacy, support, shared many experiences, and I will spare you guys my experience. But what I will say is that my experience has really informed the work that I'm doing. And then I also believe that many of us in this room has been charged and informed by our own personal experience to move forward with this work in maternal health. So today's event is focused around maternal mental health. And a lot of the work that I do as a lactation consultant, as a reproductive psychotherapist, is really focusing on maternal mental health. And in order to survive the 4th trimester and to just survive the perinatal period,
there's a universal need that all women, mothers, parents should have. And one is a companion or a support person. And that person could be their partner, a girlfriend, a best friend, a mother, an aunt, a cousin, their village. The second is a supportive or trained professional. That could be your doula, your OB, your pediatrician, any of folks in the maternal health world, right? Many of us play dual roles oftentimes. And then lastly is the time and space to share their experience. And so what that looks like is the 4th trimester, because oftentimes folks do not have a space to share their experience. But who hears those experiences first? The pediatrician, the lactation consultant. When the lactation consultant enters into the home, you ask, right, about this birth experience. Tell me a little bit. Tell me about it. How was it? And that is that begins this relationship in the 4th trimester. So what we often see, though, is that third space is not held, particularly for women of color. And with BAE, Breastfeeding Awareness and Empowerment, BAE Cafe offers this support so that we're able to hold space for women in marginalized communities to come together and to hold space with one another, to empower each other, to talk about parenting, to talk about the transitions in motherhood, and not only just breastfeeding, but to also focus on maternal mental health. And that is something that's really left out of lactation practices. So for many lactation consultants, when you go into the home and or in the office, you're asking about this birth experience because you want to know, like, how much weight did the baby gain, what was, the initial weight, how much weight did they lose, and all of these things. But we don't tap into this emotional space. And so for my work, in my bio, it said I did home visits. I no longer do home visits. What I noticed was that I was unable to go into a home to do a lactation consult and not acknowledge this emotional state that this person was in. And that took up the first half, the first 35, 45 minutes of my consult. And what I realized was that they're not mutually exclusive. And so when we talk about lactation and we talk about the 4th trimester, maternal mental health is a huge component. How did we get here?
Tech friend.
Well, I skipped. So. Okay.
So we're going to show a short video.
Not yet.
Many of you may have heard some of the controversy around it, which was the video.
Not yet, though. Nope, not yet. Sorry. Okay.
Not yet, but later we're going to watch the video
I don't know how that happened.
from Frida, Feminine Care Products, and the postpartum video that was too vulgar to be shown on TV.
Right, what's up? Okay. Yep. Okay, so this is a maternal mental health summit conference, and so we cannot go the day without really understanding maternal mental health. So many of us, and thanks to the CAN and the work that was done around the postpartum depression video in our city, but we also have to be very aware that postpartum maternal mental health is linear, and it really looks at more than just postpartum depression. So if you were to ask many folks about postpartum depression, they know that term. And a lot in our community, they'll say, I have postpartum, right? And we get it. We know what they're talking about. But it's very important for us to understand that postpartum perinatal mood and anxiety disorders are on a continuum. And that's why it's called PMADS, perinatal mood and anxiety disorders, versus PPD, or postpartum depression. Mm-hmm. I don't know what's happening. Okay. And so why should we care about this? Why should we care about PMADS? As much as we care about maternal mortality and all of the issues surrounding Black maternal health, we should be very concerned about perinatal mood and anxiety disorders, the mental health complications that are affecting many women, because it's the #1 medical complication related to childbearing women, because it's detectable and it's treatable. Thank you. And here are some numbers. These are some numbers that affect all birthing and parenting folks. 1 in 7 women will suffer from perinatal depression within 1 year postpartum.
and that's alarming to folks. I'll tell you what's more alarming to me and hits home for me is that 1 in 3 women of color will experience postpartum depression during the first year postpartum. And I'll share with you briefly a story. I have a 15-year-old and I have a 5-year-old. And after delivering, went to Penn State, had a baby, mom said, come home, went to New York, had the baby, wanted to finish up at Penn State Abington, so we ended up here in Philadelphia. I didn't talk to family or friends for the first year postpartum. None of my providers asked me about how I was feeling emotionally. And it was a time where I really, as a new mom, you don't really go, this is what you expect, right? So I have to finish school. I did that. He was born in July, and I finished school December, right? So just delivered a baby, went back to school because I had to finish. That was the expectation. But I also did not have a community. I didn't have a village. I didn't have family. It was my son's father, his family, my family back in New York. But I knew that I had to finish school, and I also knew that I'm assuming that this is what parenting is, not talking to friends. I had postpartum OCD, obsessive compulsive disorder. I washed, rewashed, clothes, bottles, had intrusive thoughts, and for 1 year had no idea until he was 12. And in 2015, I went to Postpartum Support International and realized that I had postpartum major depressive disorder and postpartum OCD. So these are things, one, it's treatable and it's detectable, but if folks are not asking the question and not leaving that up to a psychotherapist, but thinking about all of the hands that birthing people go through, that we all should be asking the question. So, and I won't go into each diagnoses, however we'll touch, it is a continuum. So it is important that you all understand that it's postpartum depression, perinatal depression and anxiety, postpartum panic, postpartum obsessive compulsive disorder, postpartum post-traumatic stress disorder, and postpartum psychosis. Now, postpartum psychosis is what we hear of in the news very often, right? And we know that that isn't the most prevalent. We'll see symptoms of postpartum anxiety, postpartum panic. Also, it's important that we're asking folks if they're having any intrusive thoughts. And that's something that a lot of medical providers are not asking because, one, folks don't want to know the answer because then they're like, what do I do with this information? But not only that, moms are not going to tell you if they're having intrusive thoughts because if I tell you this, then I'm a bad parent. So now we go back to the video, which is back.
So looking at this discussion question, keep this in your mind. What can you do to assist with reducing Black maternal stressors? Hold that question. We'll watch the video and discuss.
Yep. How do we hit play? Can we dim lights?
Well, then it's too dark here. They can't film.
Oh, okay. Is there sound?
Should be. Yeah, there's sound coming from the computer, but I don't know. I'm not sure why there's no sound from here. Unless this is turned on. No, that's not too.
Maybe just back it. Just go back from the start.
No, it's the same.
They need to read it.
Is there
How many of you can relate? Right.
The discussion question.
Where is it?
I think
It's at the end?
Well, you can go right here. Yep. Nope. I don't know.
Where?
Go back. Go back.
Okay.
Right here. Okay.
Doesn't correspond with this.
I know,
Right.
for some reason. Okay. So many of us can relate to the Frida commercial that they wanted to play at the Oscars, and I'm assuming many of us are familiar that they rejected it, right? So many of us in here can relate to that. I presume that many folks at the Oscars and in their living rooms would have been able to relate to this video. We also have to remember that this is Frida, they're selling a product, right? And for me, I can say the statement of postpartum doesn't have to be this hard. I think the wording could have been a little different, right? Because it's not that's the reality. That's it. It's I don't know how easier you can make that, right? And I don't think a Frida bottle will make it any different. So, but that's postpartum. That's the 4th trimester. It begins there, right? On top of the traumas that we experience. Because 10 years later, folks said, why did you wait 10 years to have your child? My daughter, who's now 5, because I didn't want to experience my own personal story that I had with my 15-year-old. However, when I got up and I sat on the toilet, I didn't know what to do. And I had to tell my nurses, like, hey, wait, I don't know, because the last time I did this, I almost flatlined. Right? And so that is postpartum. That is the 4th trimester. And so the question is, what can we do to assist with reducing Black maternal stressors? What can we do to uphold the community and the women and our clients that we work with to address many of the issues that were talked about today moving forward? What are some actionable steps that you all as individuals and as organizations can take so that we will not continue to see these numbers? I don't think we need to do any more research. The numbers for the last umpteen years, evidence-based, right, speak for themselves. So now it's time to move forward, take steps into action. At this point, we want to have a discussion. I know we only have 3 more minutes, so if we can have a question or answer to the question would be good. So we have someone in the back up there. You need it.
Grandma.
Right. Right, and I think thank you for that. And I think what was key was that we don't have to ask, just do. Right? We don't have to ask, just do, because we know that folks don't want to ask. Right? And I'm too prideful to ask. Many folks are too prideful to ask, so just do. I think we're going to take one more. Yes.
So the thing that was the most prevalent for me, I'm a gardener. I'm not a flower. I love doting on other people, but I don't like the attention. And my soror, my darkest days, call me every day.
Right.
And I would not have gotten through it without that. Because everybody else, it wasn't that they weren't trying. I was like, oh, fine, I'm good.
Right. Right. Thank you for sharing that. And I think on that note, the larger message to that is that individually, we need to just do. We need to, in whatever capacity that one, if it's whether it's like a personal relationship, a family member, in your place of employment, what does that look like? For your community-based organizations, what does that look like? What are you doing? How are you changing policies? How are you changing systemic racism? How are you changing these issues that we know are contributing and contributing to the issue, which is Black maternal mortality in the city of Philadelphia?
And here's how you can move from awareness to action. Black Maternal Health Week. So Black Maternal Health Week is coming up. I would love to see everyone there. We have a whole week of activities planned. We're starting out, as you heard earlier, will be the Black Health Fair. And then on Monday is our Advocacy Day training. So I want to be very clear that Monday, April 14th, is not Advocacy Day. That is where you will come to the library on the Parkway and get all the information about the bills, be matched with your state representative, understand how to speak to your state representatives at the Capitol, get your scripts, and fully understand what Advocacy Day on May 6th is going to entail. I just want to also point out that every event for Black Maternal Health Week is free. And for Advocacy Day, the only thing we're asking for is a $15 donation, and that will cover your round trip, your food all day, all the information that you need. And then we have a Black doula meetup, so all Black birth workers come out. Myself and Jatola Davis, who is a certified nurse midwife at Jefferson University Hospital, we will be doing a very candid YouTube video. On Thursday, there's the Infertility Healing Circle at the Discovery Center. Friday, we will have a community-based baby shower at the YMCA in West Philadelphia. And Saturday, we will have the Black Maternal Mortality Summit at CHOP. We have been so blessed and so thankful that the community has supported us in this manner. But it doesn't stop here because we need some more money. So I listed some community organizations and resources that center Black women. If you would like to help us continue throughout our paths, you can donate in PayPal at Oshun FAMCTR Center and help us continue to move this mission forward. I would like to just say thank you for having us. And if there's anything you need, we're both posting our contact information for you to get in touch with us. Email, my phone number is up there, but just send me a text message because I'm not going to answer. And those are the best ways that you can contact me. And I'm switching in 3, 2, 5, 4, 3, 2, 1. And here's Jabina's information.
So if you use your QR code, open up your camera, and then my information will be downloaded into your phone.
I think that might be it. I know she's so fancy.
Yeah, I get your QR code.
Look, I was on my phone last night like, what's this? That's nice. So again, thank you so much for Drexel, the CAN, and all of you for coming out to hear our portion. Stick around, it's another panel, and we're going to continue this mission.
Okay, Jabina with the QR code. All right, that was amazing. Who just learned something? Yes, yes, yes. Excellent. So we're going to take, are we going to take a break? I think we're going to take a break. Let's take a break. And we will return, or wait. Hang on one second. Okay. Yeah, okay, so go ahead and take a break, come back at 3, and we'll have our final panel.
my phone.
Do we have another PowerPoint or no?
I don't think so. All right, what a day. What a day. Thanks to y'all who've stuck it out all day, hung out with us. It's a great day to be inside. I just looked outside and saw people with umbrellas. I was like, ooh, yeah, I'm glad I'm in here. You having a good day? Yeah? Okay. All right, so right now for our final panel, I want to reintroduce Cindy to moderate our panel.
I'm back again, y'all. So one of the things that I just wanted to say is thank you all for coming, and we want to acknowledge the community members, providers, organizations, and practitioners that came here today. Give yourselves a round of applause. Thanks for coming to listen, to learn, and to be in action. I think that's what our final panel is about, like how can we, what's next? And really to gather our collective expertise around maternal trauma, discover new ways to do something better, and to imagine a vision where mothers and birthing people in Philly are no longer dying, or, here's the thing I learned, or experiencing perinatal mood anxiety disorders. So I'm gonna start using that a little more. So I'm gonna jump into introducing our panelists for What's Next, Innovative Approaches to Addressing Maternal Mental Health. We're gonna start with Miss Ebony Durant. Ebony Durant has obtained a Bachelor of Arts from Alvernia University. She works for Project Home at the Stephen Klein Wellness Center as the Centering Pregnancy and Parenting Coordinator. She loves educating moms while pregnant and supporting them once their baby has been born. She has extended her education by obtaining a license as a certified lactation counselor to offer additional support to moms. And in 2016, she became a first-time mom to a baby boy named Braxton. Since becoming a mom, her understanding of the challenges that women face has been widened and has deepened her passion for women's health, with a focus on areas such as breastfeeding and postpartum depression. She believes that with love, support, and education, we can strengthen our moms and help them in this journey called motherhood. Her superpower is she likes to interpret dreams. Give it up for Ebony. Next, we have Takara Gainey. She is a MA, CD, and doula, and a reproductive justice advocate and birth worker. She fuses her background in anthropology and reproductive work to acknowledge and address systems of oppression that impact availability and access to compassionate, non-judgmental reproductive care to birthing persons and their families across the spectrum of their reproductive needs. Takara is a birth doula, childbirth educator, founding member of the Maternal Wellness Vision, give it up, a collective integrative birth workers, as we heard, whose mission is to raise awareness and address Black maternal mortality, and now serves as the program associate for Maternity Care Coalition's Community Doula and Breastfeeding Program, providing accessible community-based doula care to birthing families throughout Philadelphia. And her superpower is adaptability. Give it up for Takara. Next is Lakeisha Garland, and she is the recently appointed director of the Family Health and Birth Center, which is of the Family Practice and Counseling Network. A lot of you know it as FPCN. In anticipation of its opening in late 2020, she is leading the community engagement strategy and marketing efforts and overseeing the design of physical space and operations. Lakeisha concurrently manages the operational oversight of Annex West Health Center, a primary care health center and FPCN network member, and she provides programmatic and clinical support to the entire network. As a key leader in the FPCN network, Lakeisha has developed policies and procedures to ensure service delivery is in line with Health Resources and Services Administration guidelines and has collaborated across work lines to optimize workflow and protocols. She has also designed initiatives to improve patient satisfaction and retention, a public health advocate and champion for the medically for the medically underserved, Lakeisha acts as a liaison between the network and community organizations representing FPCN and promoting its services and partnership opportunities. Her superpower is motivating people. Give it up for Lakeisha. And lastly, we have Dr. Carol LaRoche, and she is the Director of Integrated Care for Community Behavioral Health. Dr. LaRoche received her Doctor and Master's of Public Health and Community Health and Prevention from Drexel University and a Master's of Science in Education from the University of Pennsylvania. Dr. LaRoche's work is focused on the integration of physical and behavioral health, physical and behavioral across sectors and systems, including for perinatal women. Prior to rejoining CBH, she served as the Director of Program Integration for the Division of Maternal, Child, and Family Health of the Philadelphia Department of Public Health. And her superpower is traveling. Give it up for Dr. LaRoche. So we're going to jump right into questions and, as we said, have a conversation. And I think that since it's the final panel, we also want to give an opportunity for a lot of you to share some of your ideas about the things that you've been thinking through. How can we advance the maternal mental health field? What are some innovative approaches that we either learned today or that we've been already practicing and we want to share with a wider network to have some more collective action around and really support mental health for birthing people? And so with all of the discussions that have been taking place, what are some of the ways that we can advance the maternal mental health field? In other words, what should the system change to empower healthy, happy mamas? Don't all jump at once.
I think one of the things, hello everybody. I think one of the things that I wrote down was we should build trust with patient and our providers, build communication, educate, and be more trauma informed.
Thanks, Ebony.
When I think about advancing maternal health, mental health, I think about continuity of care and the importance of having continuity of care. Earlier on the panel today, Dr. Mehta spoke about the limitations that providers have when meeting with clients. You know, you're limited to maybe 10, 15 minutes. And within that time frame, you can't really get into the nitty-gritty of the emotional things people are bringing into their pregnancy. You can't really speak to some of the external factors that are impacting how people are navigating their pregnancy: housing instability, food insecurity, working with other children in the family, familial issues, transportation, different things that people are bringing into that experience that one visit with your provider doesn't provide you. And depending on where people are in their pregnancy, they meet with their provider once every 4 weeks, 6 weeks, maybe every 2 weeks. And you're usually rotating who you're meeting with. And so you're probably not meeting with the delivery doctor. You get to the hospital with someone completely different you haven't built a relationship with. You've never seen them before. So I think models that really promote that continuity of care, something like doulas, that's kind of the hallmark of doula care, having that consistent presence, someone that you're meeting with regularly, you're building a relationship with, someone that's really understanding what emotional baggage, what emotional things you're dealing with that you're bringing into that experience, helping you kind of navigate any other resources you may need to seek out to help you better show up for the rest of your family and yourself. And something that I'm really proud to be a part of is Maternity Care Coalition. Hey, everyone in the audience. Hey. Yes, MCC showed up today. The home visiting programs that we have at Maternity Care Coalition, meeting weekly, bi-weekly with families to fill that gap that the providers aren't filling. And it's, not really the clinical stuff, but it's everything else, right? And so your home visitor, your doula, your promotora, your community health worker, we fill many roles. We wear many hats, whereas your provider, they stay in their lane. Their lane it's the clinical stuff. Whereas your home visitor, your doula, we're the social worker, We're the therapist, we're the lactation consultant, we're the babysitter, we're the cleaner, we're the organizer, we're the scheduler, we're linking you with all these resources. So we're wearing many hats, and in that process, we're building rapport, we're building a relationship, we're tending to your emotional needs. As Jabina stated earlier, we're leaving space for that emotional download. That's really important. And if you don't address that early on, you're really setting someone up for having adverse mental health outcomes. And so tending to, just asking, how are you today? How are you feeling? What's going on in your life? How can I show up for you? And that's what the role of a doula or a home visitor is. And so I think having and investing in more trainings and programs and supporting those that already exist with home visitors is really important and one way for us to advance maternal mental health.
How do you follow that?
So, in my role as the impending senior director for the Family Health and Birthing Center, you know, for the last 5 years, I've been fortunate to work with FPCN and to understand its programs and to understand its service lines. And I'll just say, you know, we are not the answer, but I am fortunate to come from an academic institution that just didn't get it to a community-based organization that is trying. And so, you know, one of the things that we are able to provide, in addition to the physical family health, is the integrated behavioral health, the outpatient behavioral health, which is so, so important. When we think about life and we think about its challenges, we know it's not as simple as getting to and from an appointment. There's stuff that happened along the way, and getting to that appointment is stuff that happened with me yesterday. My daughter just got locked up. I got to take care of these babies, or I'm taking care of my mother and I'm sick and I have been, you know, so there's so many other things that kind of get in the way. We call them barriers to care, right? And so, you know, when we think about, you know, fusing in the integrated behavioral health approach, you know, being able to ask the questions, not what's wrong with you, but what happened to you. I think really trying to embody what it means to be a trauma-informed organization and a trauma-informed network, really honing in on what it means to be culturally aware, proficient, and getting what that means. And I think, you know, all of those, they kind of contribute to solutions, but there's still always room for jello. And I think always having conversations with community members in terms of what they need. We can sit here and say, this is what we offer, here you go, take it. But at the end of the day, it's the community that's going to be really leading the charge and telling us what they need. And so it's all call to action to be able to help provide some of those social supports and services. And so as we speak to, you know, perinatal depression, you know, understanding in this line of work how critical that fourth trimester is. I'll never forget an analogy that I heard from a Dr. Jason Baxter, who's an attending over at Jefferson Hospital. I had a previous hearing that we had attended, and he said, you know, when you think about, you know, baby and you think about mom, baby is the piece of candy. Everybody wants to get the piece of candy. And then mom is that wrapper that's outside of that piece of candy. What do? Throw it away. We toss it out. And so, you know, we have to think about mom. We have to think about her mindset. When I think about my own experience, I bring my own experience to this as well. You know, my baby is 10 years. But I had a traumatic birthing experience as well. And it was one of those things where I didn't want to share with anybody. And we hear these stories time and time again. And, you know, no one took care of me. I didn't know how to take care of me. And so if someone asked me, what can I do for you? Or if someone asked me, if my provider said, how are you feeling today? Perhaps things would have been different in those months, you know, that I was taking care of that baby. And so, you know, as we think about, you know, how we're going to enhance and tailor service lines to be able to make a difference, you know, it's so important for us to listen. It's so important for us to not only listen, but it's also important for us to act. It's also important for us to have collective conversations in terms of best practices. Oh, you did what, girl? Let me go ahead and go back. Okay, so, it's not just, we're not trying to monopolize anything. I don't think anybody should be in this line of work to monopolize a service line. It's all about village, it's all about community, it's all about collection. Thank you. Did I answer the question? Did I answer it? And then some.
And then some.
More to come.
Okay.
So there are several ways that we can advance maternal behavioral health. Dr. Headen this morning talked about stigma and bias in healthcare. So and it's well documented, the stigma, previous experiences with the healthcare system, in this case behavioral health system, may really prevent women from seeking, in this case, behavioral health treatment. So I think one way to advance that is to really train clinicians about how stigma prevents women from seeking treatment, and also about having culturally sensitive conversations about behavioral health conditions, because they themselves can be stigmatized. So really having these conversations. And that's in general in the healthcare system, but when we talk about behavioral health too, I think with respect to workforce development, even in the behavioral health system, there's very few providers that can actually really treat perinatal behavioral health conditions. So we really need to work on workforce development and really create systems for reproductive psychiatry and use other systems like technology, e-consults, telehealth, to help those providers that may come across women with behavioral health conditions. So really there's a lot that can be done in technology that we don't avail of. Dr. Headen also talked about this morning about not connecting the systems, not connecting the dot, working in silos. So I really believe in having an integrated care system where behavioral health is integrated in primary care, in obstetrics, in pediatrics, to really have a seamless system. And lastly, the maternal wellness village ladies talked about the 4th trimester. Well, unfortunately, sometimes our women, particularly low-income women, do not have coverage in the postpartum. That's when behavioral health conditions are likely to arise. And so that poses another barrier to treatment, particularly when those conditions were identified during pregnancy. So that treatment is disruptive. So thinking about various ways that we can really advance.
Thank you. And so, Carol, you spoke a little bit about the behavioral health system and there being some stigma around that system, there not being really enough of the reproductive psychiatry workforce, so that we need to bring up some of those things so that there's more folks that are doing this kind of work. Can some of you all talk a little bit more about what are some things that are getting in the way that could be stopping us, or what are some of the challenges of advancing the maternal mental health field?
I think, again, like I said, a lack of trust, a lack of communication, a lack of us providers, healthcare professionals being relatable. I work at Project Home at the Stephen Klein Wellness Center, and we do centering pregnancy and centering parenting groups. And what that does is give providers and patients an opportunity to build a relationship with one another. Their appointment, patient's appointment, is a 2-hour appointment. We spend about a half an hour to 45 minutes with patients. They get their individual appointment with their provider, and then we get in a group setting and we do education. We educate on nutrition, why dental care is healthy during pregnancy, breastfeeding, family planning, domestic violence. We have our partner here that comes and talk about doula services. What is a doula? Because how do you get to trust someone? You spend time with them. You communicate with one another. Just like when we meet that guy, we hope that they court us. And we date. We get to learn each other. So in centering, it's good because like someone said earlier, one of our providers earlier said that doctors are held to a 5-minute visit because they know that 3 moms are in the room and about 10 more is out in the waiting area waiting for them. So they can say, okay, I need you to breastfeed because that's the healthiest thing for the baby. But they don't tell us how to breastfeed. And no one told me how to wean because my son, we told his age, but they don't tell us how to wean. So I'm here and I still don't know how to wean, but I know how. But, it's a struggle because if I know what I know, so just building that education. So how to breastfeed, what are the positions? How does our body make milk? I had one nurse at a hospital say, you just breastfeed, but no. A breastfeeding experience for someone that lives out in the county, that has her husband home, that has a nanny, that has all these resources and all this support is totally different than a mom that's home by herself with 4 other kids. Dad is incarcerated, or maybe he's locked up, or maybe he's just simply not involved. So we sit down and we build these relationships in centering because our providers, one of our providers is here today, Tina and Julie, our nurse, we get to, if a mom says, I'm struggling, Tina says, me too. And we build that relationship. We know that it's okay to say, well, I didn't sleep all night and I'm frustrated. Because Tina will say, well, I remember when I didn't get any sleep for 2 nights. So we build that relationship. We communicate, we become relatable, and I think that's what the health system is lacking, the time to build that trust, to communicate with one another, and to be relatable to our patients.
Thanks, Ebony. Takara, I know you said something about like following best practices in models, unless it was Lakeisha. Let me just make sure I'm okay, Lakeisha. I'm like, so can you think about some of the other models that maybe you've seen? Like, I know we're talking about centering, that could potentially be a best practice model that maybe some other folks are not aware of. And same thing for you, Takara. If there's any models that you can think of, I know MCC is one of them, but are there any others?
Well, I just wanted to piggyback off of what Ebony said about really building that trust and spending that time. And I think the home visiting model, that continuous care is one of those things that builds that trust, identifies when something might be off, and building that trust of the individual to say, you know what, I'm not feeling okay today. And what does that mean? And throughout, there's certain touch points throughout pregnancy, and then, that infamous 6 weeks postpartum that folks get where they're screened for postpartum depression, right? It's like a 10-question test, and it's very easy for answering bias to come in and people to just give you an answer that they think you want to hear for a variety of reasons, for fear of stigma, of being judged or mislabeled, the real fear for Black and brown women of having their kids taken away by DHS, or just not really knowing what that conversation about feeling depressive symptoms or feeling overwhelmed or feeling a range of emotions when they expect or they were told, during this time this should be the happiest time of your life, and if you're feeling anything but happy, something's wrong. You're not right. You're not fit to be a mother. And so creating that trust, having that model of care that continuously asks and updates, how are you doing? How are you feeling? Knowing that someone's going to come and see you and call you and check in on you. The individual, right? The parent who becomes that wrapper, not tossing that wrapper, but holding on to it, right? Smoothing it out. Maybe put another candy in if you can, right? And so having a model that does that is really important. And I don't know of any other models that might be conducive to advancing maternal health, but it really goes back to that continuity of care for me. And then I also want to speak about the burden that we put on the individual to then go seek care or treatment if it is recommended. You know, if you're already feeling overwhelmed, when you're at home with the newborn, just putting a coat on the newborn, washing yourself up, that takes a lot out of you. And that's it. At that point, you don't want to go anywhere. You done did your task for the day. That's it.
Right.
I'm not going to go and call all these people and figure out who has an appointment, who takes my insurance. I got to get over here all the way across town to go to this therapist because they're the only one within my network. So the burden falls on that individual to then get the care that they need. So it's not enough just to identify it and label it and say, okay, well, I think you may need a little extra support. I think you may benefit from talking with someone. Here you go. Right? So allowing or having some type of system that brings those services to them, right? So like in-home therapy services, or what the maternal wellness is promoting is having that hub for all of your needs, right? And so a person can show up and, you know what, I need lactation support. Go down this hallway, we got someone right here for you. You know what, I need to have my mental health session. All right, let's go down this hallway. We got your psychotherapist right here to talk with. You know, I really want to just like bond with some other parents. You know, I feel lonely, I feel isolated. Okay, come on over here. We got a little parenting group going on, so you don't feel so alone. So having those systems that are integrative, that bring the services to the individual and not put the burden on them, is also really important and something we need to look into.
I would agree with all of the above thus far, but I think destigmatizing asking for help. Because a lot of times we feel like we should not have to be asking for help. Destigmatizing mental health and wellness. A lot of times we're ashamed to seek out the supports because of how we're going to be looked at. And so with all of that, just like my wonderful sisters have said, to create space and trust and opportunity to be able to have a dialogue for mom to be able to relay, listen, let me tell you about last night. I'm tired, child. I need some help. And for our providers to be readily available, what do you need? Well, you didn't eat last night. Let me call the nutritionist and get her in here so we can talk about a meal plan or some meal preps. Let me go ahead and holler at Sister Christine, who's going to come see you at home. We're going to schedule some appointments at home so she can check on you and the baby, you know, more often. Let me go ahead and see our mind-body practitioner who can help with some stress, de-stress, okay? Let's see about, you know, I think just taking all of that into consideration. When you think about all of the needs and the challenges, especially as a new mom, we need to understand that, and are we able to fuse some of that service work into a healthcare setting or into a community-based setting? Are we able to provide child care services? Are we able to do that? Next, I'm going to say we need money. We cannot keep trying to rob Peter to pay Paul to make some of this stuff work. It's not right. Listen, I ain't going to go there today. But there are some other initiatives that are getting millions and millions of dollars. You better go ahead. You better know it. Millions of dollars. Every time I turn around, there's a new. On the news? We saw the stop of the safe injection site. However, centers of excellence are opening up all around. And it's affecting. It has affected a lot of people. Yes, it has. This affects a lot of people. And so for us, we're talking about it, and there is definitely strength in numbers, and we know that we're raising the awareness, and the beautiful people, all of us are doing this work. Show me the money. We got Governor Wolf, the CDC grant, $2.5 million. What is that funding in terms of sustainable funding, people? I think it's beautiful and I think it's great. I think it's a start, but I think it's a start. And we need to continue to have the conversations. When we talk about the Merck for Mom initiative, it's $1 million. that's great. I think it's great. It's definitely a catapult and it's a stepping stone. But as we think about this line of work, longitudinal trajectories, we need sustainable funding. We need a line item on the budget for this. Thank you.
Kara, I want you to respond, and then I want to ask the panel a lightning round of what's one action people can take starting tomorrow. But respond to everything, to whatever you want, and then answer the question.
I agree here with my colleague that I think behavioral health, particularly mental health, is not a priority. So I think we need to make it a priority and advocate for, put it in the top of the agenda when we have an opportunity. So it does have more of an impact.
Thank you. And so the question for you all is, what is one action people can take starting tomorrow? And then I have a question for the panel and the audience. So if you can just share one action that people can take starting tomorrow.
So I will say there's no need to reinvent the wheel. We heard today of a lot of groups that are currently active, that are doing important things, that are led by and for Black women. Show up, support, put those coins together, donate, yes, and allow them to lead the work. That's it.
Thank you.
I think consistent with the theme of this conference that we need the village to move this. So again, to your point, we all have to come together and advocate for these women and for their voices.
Thank you.
Yes. I agree. I think when the village comes through, there's strength in numbers. And I feel like the advocacy is so needed and is so crucial. But in addition to that, I'll also say, just like my sister just said, to support the initiatives that are happening on a community-based level, on the next tier level, and all of that good stuff. Definitely show up, show out. Again, we are each other's support systems, and so let's continue to support one another, but also advocating for those who are voiceless and making sure that we're taking all of this back to our workplaces and advocating for them in that right. Thank you.
Yes, I agree with everything I've heard. I think we, starting today, starting tomorrow, can remove our biases, remove any judgments that we have, meet people where they're at. We have an ideal of what they may need, but what we feel they need may not be what they need at that time. So listening to our patients, meeting them where they're at, building that trust, building that communication, and finding this money.
So I have a final question that's inspired by Miss Salima. How can we stack the village, y'all? This is a question to everyone. You can throw out one-word answers. We can do a sort of lightning round. What are some ways we can stack the village? Education. Support teen mothers. What was another one? Respect. Humility and consistency. Listen, y'all. Collaboration and communication. Referrals. Unconditional positive regard. Accountability. Resources. Cultural sensitivity. Pull in the man. Yep, men. Men. Multiple. Other ideas. Advocacy, as we heard over and over today, right? We want funding, we want Action, we want change. Advocacy. Other ideas? Get political. And what was the other one? Vote. Combine. Get political. Vote. And say that again. Inclusiveness. Other ideas? I heard better sex education, and then I heard, what was the other one? Community-based participatory research, y'all. Say that again. I would make you say it again because I just like the way you said it. Promoting self-love, especially when you're talking about healing and mental health. We want to do that. I know that there were a lot of people who shared their stories today, shared their trauma. Please love on yourselves this weekend a little bit. All of you who've heard stories, who felt emotions, promote that self-love. Love on yourself. Pay people who share their lived experience. Pay people. I don't think I got to repeat that one. Share this. Uh-huh. Share this message everywhere besides here in these spaces. Everywhere you go, share the message. I think I heard one panelist earlier say, you know, when you talk to people, when you talk to your providers, you know these statistics, you know these ideas, you know these solutions. Make sure you share that information, share that wealth of knowledge with others on your day-to-day basis. Maybe, can I get 2 more? Yeah. We got to get behind the walls in the prisons. Other ideas? How can we stack the village? Mentor. It's really important to have people that you pull up with you as you climb, right? Whether it's as a practitioner, as a community organizer, even if you're a big organization and you want to mentor a little organization, bring them up as you climb. Access to health care. We want to stack the village. People need access. And food. And housing. And what? Food security, y'all. People need to eat in order to have healthy babies, right? Nutritious food. Let's get rid of them nutritional food deserts. Intersectionality. The Kimberly Crenshaw version, y'all. That one.
I'm going to even specify that. Please highlight our queer folks, our black trans women, our immigrants, our indigenous folks. Please make sure you're including them in your definition of maternal health. Yes.
Miss Sammy Schuster is passing around an evaluation. Please fill it out. This will definitely support us in figuring out how we want to make this even better next year. Thank you all for your participatory energy and for being engaged in the conversation. I wish we had more time, but I'm also a stickler for time, so it is just about to be 3:45. Any last thoughts? Anything anybody's pressed to say before we close out? Thank you. I'm going to pass it over to...
Thank you. Closing remarks will be brief. So yeah, fill out the evaluation. And I want to say some thank yous. Let's see. First, let's thank our sponsors, the people who provided the money for this event to be a thing. I'd like to thank the Philadelphia Department of Public Health Healthy Start Program. I'd like to thank Drexel University College of Medicine, Behavioral Health Care, and Drexel Maternal and Child Programs, and the Philadelphia Community Action Network. A special thanks to all the volunteers today. for making this event a success. And I want to offer some special thanks to Rhonda and Jessie. Where's she at? There she is. I want to thank Larry, because we'd be lost without you. Thank you so much. I want to thank Kyung. Is she in here? Well, thank you, girl. Thank my girl, Kiki. And I really want to give, y'all don't even understand. I want to thank Samantha Schuster, because truthfully, this would not happen without her. That funding thing that happened, that was her idea. You know, putting a little bit of dough in people's pockets for being on this stage today. And I'm right here. You can come up here, sweetie pie. It's okay. I also, what was I gonna, anyway, people say a lot about allyhood and what being an ally is, and yeah, I'm an ally, you know, I signed a petition. Samantha Schuster is an ally. She's a down human being. She's really, she's the bomb.com. Anyway, thanks, Sammy. Okay, so before you leave, please take time to complete an evaluation. If you're requesting CEUs, make sure that you get your paperwork to the registration desk. Thank you so much for coming. I hope you learned a lot. Share stuff on social media. Share stuff in your workplaces, in your homes, in your communities. And have an excellent weekend.